It's my privilege to introduce Dr. Purvi Kulshrestha. She is faculty at AIMS Rishikesh and Associate Dean also at Academic Affairs at AIMS Rishikesh. She did her MD Physiology from AIMS New Delhi, and currently she is doing research in the field of cardiology and sports medicine. Her area of interest is intraoperative neurophysiological monitoring and autonomic function testing. And with her most recent publication is very impressive, autonomic nervous system profile in fibromyalgia patients and its modulation by exercise. And she has a numerous list of research papers which are highly cited. So I am all excited about her current talk on stress, neuroendocrine and autonomic correlates. So let's, Madam, could you start the session, please?
Yeah. Thank you, sir. Thank you for a nice introduction. And I also am thankful to the organizers for inviting me for speaking on this topic in this meet Epicon 2021. So the topic is stress, neuroendocrine and autonomic correlates. I'll slightly go off track because I want to introduce the audience to what is stress, because there has always been a lot of debate about what is stress, what are different kinds of stressors and how do they affect the nervous system. So why should we be interested in stress? Because it pervades all aspects of our lives. It has been a epicenter of discussion in the folklore as well as in mass media also. And the public documentation of stress goes back to First World War, when PTSD, post-traumatic stress disorder, was discussed amongst the soldiers who had been victim of shell shock injury especially. And it has always also been the focus of best-selling books worldwide. So you can see a lot of editions of the Time magazine discussing stress and how does stress affect the work performance, the family life, and health as well. So the humdrum and debate about what is stress. Is it the pleasantness about the events which are happening in the outside world, or is it about the changes that take place in the body? Is it about the what does the brain do to the body, or what does the peripheral stressors do to the brain? So there is a lot of debate and discussion about the neurobiological and psychological aspects of this stress. And also individuals, they respond differently to stress. What may be a stressor for me may not be a stressor for the other person. So here lies the neurobiology of the stress and how does neuroendocrine system act. The stress physiology in the last century, actually the credit goes to Sir Walter Cannon, who is the pioneer of stress research, and then Hans Selye is the father of stress research. And he also got a Nobel Prize in 1949 for this purpose. And he also stressed upon the role of glucocorticoids in the stress biology. And incidentally, the last century had focused on the first half of the neuroendocrine loop. That is, how does the brain initiate stress response? But however, gradually the focus has also been shifted to how does the stress response itself do to the body. So before I go to the neuroendocrine and autonomic correlates, let us discuss about the evolution of the framework of the stress system. There is a stimulus stressor, then stress, yes, and then stress response and effect. But however, gradually it was felt that there should be a sensor as well, which can decide that what stimulus would act as a stressor and what stimulus would not act as a stressor. And in this framework, the second panel, which shows that homeostasis is actually the one which is the deciding factor. If homeostasis is disrupted or challenged, then it results in stress and stress response respectively. And if there is no stress, no challenge, then there is no stress. And accordingly, the stressors have also been defined as just a minute. As this bad stress, which is called distress, as well as stress, where there is inadequate stress response. However, homeostasis itself is a little bit of stress is required, which we call as a good stress or eustress. And it also acts as a buffering agent that it brings about positive changes and increases the synaptic plasticity. So stress response, in order to understand the stress response, it is important to understand various types of stressors, the interoceptive stressors, stereoceptive stressors, and the stimuli mainly are physical stressors and psychogenic stressors. Physical stressors include those changes or stimuli which actually challenge the physiological system. It could be hemorrhage or infection or even pain. Whereas psychogenic stressors are the stimuli that are actually real or maybe anticipated, could be environmental or predator related cues and failure to satisfy the internal drive. So time of stressors on time scale have been divided into acute stress, chronic stress, life stress, and daily life hassles, which are actually defined on the basis of how much do they last, how long do they last. Acute stress is always short term, chronic stress is prolonged. Life events and daily life hassles are the ones which we face daily in daily lives. And all of these stresses which have been demarcated or differentiated on the time scale are very relevant for health, and they give rise to stress reactivity, as well as chronic stresses give rise to, they run the risk of chronic illness, mortality, and accelerated biological aging. So there is a central stress response system which encompasses both the neuroendocrine as well as the autonomic neuraxis. So if there is a stressor, uh, the hypothalamus, pituitary, adrenal axis, as well as the sympathetic adrenergic system, both of them, they act to bring about peripheral adaptation. On the right hand side, we can see that paraventricular nucleus and locus coeruleus, these are the centers which are mainly responsible for giving rise to both kinds of neuroendocrine and autonomic stresses. And apart from this, you can also see that there is a central autonomic network system which actually into which is embedded the central stress system. So we have some areas in the prefrontal cortex, in the midbrain, in the brainstem as well, which are actually giving rise to both kinds of effectors. So we have some mediators like AVP, cortisol releasing hormone, then we have SNS and PNS, so that the sympathetic nervous system and parasympathetic nervous system acting together. However, the sympathetic nervous system and parasympathetic nervous system, they actually are to some extent contradictory in their action. Then extended autonomic system has also been discussed in reference to the central stress response. That is, apart from the classical Langeles ANS, which just comprises of the sympathetic, parasympathetic, and the enteric nervous system, there is now discussion of including the neuroendocrine systems, namely through the AVP secretion, HPA axis, sympathetic adrenergic system, and renin-angiotensin system. And also it includes immunity and inflammatory part also, which I'm not going to lay stress upon in today's talk. So the stress system, as we have discussed, the physiological stressors and the psychological stressors, they both give rise to a particular stress response and affect the whole body by bringing about changes in the energy mobilization, especially in the brain by bringing about genomic and epigenetic effect, and also non-genomic effects in the brain by and increase the immune reactivity. So the end result is adaptation to various forms of stress. So the HPA and the ANS responses to stress, if we can see on the left side is the classical sympathetic axis, which also innervates the adrenal medulla. And on the right side, we have the HPA axis, which through ACTH secretion from the anterior pituitary innervates the adrenal gland, and from the zona fasciculata gives rise to the secretion of cortisol. So that is how these systems, both systems, they run parallelly and respond to stress. However, there is a gap, that like there is a time range when these effects can be manifested. For example, through sympathetic nervous system, the effect is immediate, but by neuroendocrine and ACTH pathways, the effect takes a longer time. And this is very important because the sympathetic nervous system generally, it responds to the physical stressors. So through reflex action, it has to act faster. So that is why the immediate effects are there. However, the other part, the HPA axis, takes longer because there are a few connections involved, and that's why it takes minutes or hours depending on the pathway which is being discussed. The neuroanatomy of stress, again, we can see that prefrontal cortex, then we have amygdala, hippocampus, locus coeruleus, nucleus tractus solitarius, the human brain, which are very active. And on the right-sided box, in this C diagram, we have physical stressors, the areas which are responsible for responding to the physical stressors, which are paralimbic system, hippocampus, paraventricular nucleus, the central nucleus of amygdala, which are more important, and locus coeruleus is obviously very important. And the other blue colored figure, this is actually the centers which are responsible for the psychological stressors. In this, the main important centers, apart from the centers which I have discussed in this pink diagram, hippocampus, then we have ventral tegmentum, nucleus accumbens, and paraventricular nucleus. These are the ones which are very important. So the stress regulatory pathways actually have both top-down regulation, where limbic system has a role, which and the bottom-up regulation, where brainstem, it responds to various types of stress signals. And both top-down regulation and bottom-up regulation, they actually affect the the output system through acting through the HPA axis and the sympatho sorry and these sympathoadrenolomedullary axis. So it is said that eustress and distress may coexist, and the stress responses are generally bidirectional. They can be protective or they can cause damage. So it is seen that catecholamines increase pro-inflammatory cytokine production, whereas glucocorticoids may inhibit the pro-inflammatory cytokine production. Catecholamines, on one hand, may increase heart rate and blood pressure, and it may be actually a positive sign because it helps when you are changing your posture. For example, you are getting out of bed in the morning or climbing a flight of stairs. However, chronic elevation of catecholamines, which may result in chronically increased heart rate and BP, may be detrimental and may cause some detrimental pathophysiological changes. So that's why the concept has been discussed that stress is something which disrupts. It is some real or anticipated challenge which disrupts the normal homeostasis. So allostasis was introduced, which says that the system remains stable by being variable. In this, the set point for homeostasis actually is variable. The set point may also be raised to a newer value. And this has been termed as the allostatic load. That means some amount of wear and tear is actually existing with the allostasis if there is a chronically repeated stress stimuli. So in this case, the set point would be altered, and the allostatic load, if it is there, and if it is persistent, then it can give rise to various disorders. So allostatic load types have now been defined and categorized into multiple categories. The topmost graph shows the normal stress response on the time axis, whereas the lower four graphs are actually showing four patterns of the allostatic loads. So the brain has to respond differently to different kinds of loads, and the HPA axis and autonomic axis, the response of these two axes actually determines the severity of stress response. So various types of allostatic loads are, if there are multiple hits, that means the stressor is being repeatedly coming and going. The second type is if there is a lack of adaptation. Actually, there is no proper physiological response. Then the third is that the response is prolonged. That means it is taking a longer time to recover, to get back to the baseline. And the fourth one is if there is an inadequate response, that means the stress responses, the functionality of the HPA and the autonomic axis is disturbed. And often this concept has been discussed that the stress response is actually inverted U-shaped. So inverted U-shape has actually been discussed in relation to the secretion or the levels of corticosterone. So if the levels are lower, that means they are between 10 to 20 microgram per deciliter, then the response, the stress response is considered as stimulatory or positive or the salutary response. However, if there is a persistent stress, the cortisol levels are rising, then it gives rise to stress. It gives rise to stress and the effects are deleterious. So that is how they have discussed. And the actually the reason why this is happening is that there are two types of receptors for glucocorticoids. One are the mineralocorticoid receptors where they can bind, and the second are glucocorticoid receptors themselves. So the MR receptors, they are actually high affinity receptors which are activated when corticosterone levels are low, and they are responsible for increasing the synaptic plasticity. Whereas the GR receptors are low affinity, high capacity. That means glucocorticoid levels are higher, only then they will be able to bind to GR receptors, GRs.
Dr. Purvi,
And
please summarize the.
okay.
We have 2 minutes.
Yeah, yes, sir. So apart from these two types of receptors, there have been some changes which are have been discussed in the prefrontal cortex, hippocampus, and amygdala. And we can see that there is a atrophy of dendrites and decrease in the number of neurons in the prefrontal cortex and hippocampus. Whereas in amygdala, you can see that the results are entirely different. In fact, they are opposite. Here we can see that the dendritic spines are formed and there is enhanced dendritic branching. So does it mean that amygdala has got a positive synaptic plasticity? Is it going to help? No, actually it does not happen. In fact, such responses in positive side in amygdala, which are increase in the neuron number, they actually consolidate the fear response to stress. So in fact, all these changes are, they are actually opposite, but they are working in the same direction. The epigenetic determinants of these stressed neurometrics, they start from in the prenatal life and persist in the adulthood, and mainly they are because of methylation of the glucocorticoid receptors in various sites. So I'm not going to discuss that in detail, but however, they give rise to stressed neurometrics in the person who is having chronic stress. So consequences of stress, if we can just see them for psychological, behavioral, and physiological consequences, then interactions, I'm taking example of fibromyalgia, which we have studied. And we can see external stressors, genes and environment, they give rise to certain physiological, psychological, and behavioral changes in fibromyalgia. And it is mainly the exogenous stress in fibromyalgia, which gives rise to a hyperadrenergic state and gives rise to the characteristic symptoms of pain, allodynia, insomnia, anxiety, etc. in fibromyalgia. These are our publications emanating out of the work on fibromyalgia. And commonly used biosignals, just to summarize, biophysiological indicators and biochemical indicators, both working in sync and are the actually determinants of the functionality of the HPA and autonomic neuraxis. Then heart rate variability, and just to summarize that stress and heart rate variability has been studied in literature, and it is found that if the heart rate variability decreases, that means it's a detrimental effect of chronic stress. So there is a stress reactivity hypothesis which says that if there are sustained increases in BP or heart rate in response to acute stress, that indicates, that predicts a greater risk of future ill health. some intramural projects related to stress physiology in our department, effect of music on subjective pain perception and sympathetic reactivity, correlation of burnout in physicians with specialty and years of experience. These are right now going on. So stress is ubiquitous. I would like to summarize my talk by this famous book of Robert M. Sapolsky, who writes that why zebras don't get ulcers. Because the only challenge they have to face is that they have to run away from the predator, and then they get back to grazing and playing in their normal business. So we need to stop running and when we are not being chased. And in a nutshell, it also tells you that it is important to build up a social support and indulge in some physical activity regularly that keeps the stress away. So that is the end of my talk. These are the references. Thank you. Thank you, sir.
Oh, thank you, Dr. Purvi. What a talk. Before we go any further, and I would like to introduce my co-chair, Dr. Sujata Gautam. She is Director Professor at Physiology Department, Lady Harding Medical College, and looking after various academic affairs also. So, Madam.
Yeah.
I have a lot of questions which we will take up in the team maybe. And so just to briefly, can you tell us about your work in intraoperative neurophysiological monitoring, which you did in AIMS probably?
Ma'am, this is not related to this topic.
Okay.
Yeah, yes.
So that's the different, it's not in this field you have done the, means the
stress physiology. We have an autonomic function lab in our center.
Okay, in
And,
AIMS Rishikesh, you are
yes.
working on this field.
And I've been trained in AIMS Delhi as an MD student, where I worked on fibromyalgia.
Okay.
And that itself has found some significant evidence that stress is a major determinant of fibromyalgia.
So can we, by what are the ways by we can reduce the stress, the effects of stress, the hazardous effect? Are there possible mechanisms? So is it reversible? That is what I ask.
Reversible, though I don't think it is reversible. We can stop progression. That is one thing. And like the changes I have shown you in the hippocampus and amygdala, I don't think that they are reversible. Because most of the studies which I have produced here today are actually based on the animal experiments. They have been actually extrapolated to the human beings, and in the human beings who are suffering from various kinds of psychiatric disorders, depression, anxiety, or even Alzheimer's. Functional neuroimaging has shown that yes, these areas, the areas which I have highlighted in some of the slides, they are showing hyper or hypoactivity. So that is how we can, but I have not directly worked in that area.
Okay.
Yeah.
Thank you, Dr. Purvi.
Okay. Thank you.
A good.
Okay, if there are any audience questions, they can either send in the chat box or they can ask, speak also. Yes. In the meantime, I would like to congratulate Dr. Purvi once more. Learning about stress can be so relaxing and rejuvenating and joyful experience. I came to know today. So, but we can invite some questions. Are there any?
Yes, Dr. Sujata ma'am asked about the treatment of stress. We know that if we give defibrillation, then the heart resets. And before lecture was in the previous lecture, insulin was given in gestational diabetes, but in those patients.
So I think we can call the end of this session. Thank you, Madam, once more, and thank you all the audience and my co-chair for the lively participation. Okay, next is free paper presentation.
Thank you so much, ma'am. I request the chairpersons to please felicitate our speaker.
Okay.
We thank Dr. Purvi Kulshrestha for excellent presentation. We thank the chairpersons, Dr. Sujata Gautam and Dr. Lalit Gupta, for chairing the session. Thank you, ma'am. Thank you, sir. I now request Dr. Madhulika Kabra from AIMS New Delhi to please felicitate our chairpersons. We thank the chairpersons and the felicitators once again. Thank you, sir. Thank you, ma'am. We now proceed with our next event for the session, free paper presentation. The judges for the same will be Dr. Mary Vibha Lakra, Professor in Department of Physiology, Lady Hardinge Medical College. The next judge would be for the session, Dr. H.N. Malik. We request Dr. H.N. Malik to please judge for the next session. Sir, most of them are virtual. Except one. One is offline. Highlight कर देते हैं सर. Before beginning with the free paper presentation, I would like to inform the rules of the session. Since it's a competitive event, the time for speaking per session would be about 8 minutes. Candidates are requested please not to exceed the time limit. Our judges, though very friendly people, would penalize for the same. I would request judges to please restrict the maximum number of questions to bear to 2, since we have a lot of events pending and we have a lot of contestants here also. Once again, I request the candidates not to please exceed their time limit of 8 minutes. A warning bell will be rung 1 minute prior to the ending time. So after 7 minutes, there will be a warning bell rung, and we request you to wind up your presentation in the last 1 minute. We may now proceed with the paper presentation. All the contestants today are on the virtual media except one offline candidate.
Good morning. Should I start? Good morning. Should I start? Good morning, everyone. I'm Dr. Sangeeta Bhamra, Professor, Department of Pharmacology in Government Medical College, and Hospital, Chandigarh. First of all, I would like to thank the organizers for giving me this opportunity to present our work. And our work is, it's entitled A Study to Assess the Awareness and Perceptions Regarding COVID-19 Prevention and Management amongst undergraduate medical students at a tertiary care hospital of North India. As we all know, that COVID-19 pandemic has been a grave threat to the public health globally in the last 2 years. And during this period, a point had come when the pandemic had overwhelmed the health sector. All our healthcare professionals, they had a tremendous physical and mental pressure. So a need was felt to increase this manpower, and government started recruiting them retired senior doctors, and requested the junior doctors to volunteer their participation in healthcare of COVID patients. At that time, a need was felt to utilize the services of medical undergraduate students. They can be a major manpower source for this healthcare system. They can be of help not only in providing healthcare, but also in educating the patients, in educating the public, and also in allaying their anxiety. In addition to that, if they are well versed about the pandemic prevention, management, and other aspects related to it, then they can take care of themselves in a better manner. So, keeping all this in mind, it was imperative that they had, we needed to know that they had the right knowledge and perceptions about the disease and its management. Therefore, this study was planned to assess their level of awareness and attitude towards this disease. So our aims and objectives included to assess the awareness and perceptions of medical undergraduate students regarding the prevention and management of COVID-19 infection. The objective of the study was to get an insight into what type of further sensitization and training needs to be imparted to them before their services could be utilized for patient care and other things. So methodology for this, we used a cross-sectional question. It was a cross-sectional questionnaire-based study. It was conducted over a period of 2 months in a hospital. Before enrolling them, a written informed consent was taken. The Google form-based questionnaire was distributed online to MBBS students of all the 4 batches via email and WhatsApp. This questionnaire comprised of 3 parts. First part was about demographic details of the students. Second part had certain questions to assess their knowledge about the transmission, treatment, COVID-appropriate behavior, and prevention of COVID-19 infection. Third part of the questionnaire had 10 questions to assess the attitude and perceptions of students regarding vaccination, psychosocial support, importance of psychosocial support, and health education campaigns. The questions to assess knowledge were multiple choice ones. Each correct response was awarded 1 point. The questions for assessing attitude were recorded on a 5-point Likert scale. That was strongly agree, can't say disagree, and strongly disagree. The categorical data were expressed as frequency, percentages, mean, and standard deviation. And data from all the 4 MBBS batches was then analyzed and compared using ANOVA, and a p-value of less than 0.05 was considered statistically significant. 381 medical undergraduates participated in the study from out of the total 500 students at that time. So this was the general distribution of students that participated. Age was from 18 to 25 years, and students belonged to Chandigarh, Punjab, and Haryana predominantly. 36% students had at least one family member who was a healthcare worker. Our observations: average knowledge score of students was about 70%. Most of the students were aware of the fact that COVID patients transmit the virus even in the absence of fever. The majority knew that most of the patients can be treated at home with minimal medicines, and everyone did not need hospitalization. The students also had good knowledge about various medicines that could be used to treat COVID-19 patients. However, only 47% students knew that the rapid antigen test is not a highly sensitive test for the diagnosis of COVID-19 infection. One question was about sources of information regarding COVID-19 for the survey participants, and we found that social media was considered as most important source for for the students, and next was website and internet, and after that news channels, and some took information from healthcare workers. Participant regarding observations about attitude and perception, they had a favorable attitude toward disease prevention and management, and majority of them agreed that health education campaigns have a vital role in preventing COVID-19. 2/3 of students felt that general public was not practicing COVID appropriate behavior adequately. Students were well informed about COVID-19 vaccines, including the type of vaccine, the time taken to develop protective antibodies, and the need of vaccination in a recovered patient. On an inter-batch comparison, MBBS phase 2 students had significantly higher knowledge and aptitude scores in comparison to other batches. This was the batch that was with us that we were teaching in pharmacology. So this was the comparison between
Last 1 minute.
batches. Okay. Regarding perception about their engagement in COVID-19 management, the junior most batch surprisingly showed maximum responses, maximum enthusiasm, and their score was the best. This was the questionnaire and results. So average knowledge score of students was lesser in comparison to some other studies, and it needed to be improved. Higher scores of phase 2 students could be attributed to pandemic module that was being taught as per CBME curriculum. We were teaching them about COVID at that time. Majority of students believed that their academics were affected. This was not in line with another study. It was realized that availability of good e-learning platforms at such situations, scenarios can be of help. About sources, that there is a need to cite them about scientific databases like PubMed for seeking information.
Ma'am, time
So to
up.
conclude, this is the conclusion that we need to keep the medical undergraduates updated about the disease and its management. So we should conduct seminars, workshops, and hands-on training sessions to make them better equipped and motivated in rendering their services in future crises if required. Thank you.
Yeah, thank you, Dr. Sangeeta,
Thank you, sir.
presenting your work. Before I make it open for discussion, I have one question. Did you take any ethical clearance for your work?
Yes, sir. We took the ethical clearance from our institutional ethical committee. I have that number also.
Yeah, but it was not mentioned in your presentation. That's why.
We took ethical clearance, sir. First
Yeah.
research committee clearance, then ethical clearance. So total clearance then was given by research ethical committee.
What was the average age group of the subjects?
Sir, 18 to 25 years was the range.
Yeah, that's range I saw. I'm asking about the average. You didn't calculate the average group.
No, I don't have the number right now. We
Okay.
calculated. It automatically came from Google Form, but I don't.
Any questions from the audience?
Were there any qualitative questions?
Ma'am,
Open-ended questions were there?
can you hear me, ma'am?
Yeah.
Hello?
Yes, now you are audible.
Only
Ma'am, just
MCQ questions were there, or open-ended questions were also there?
So they were closed-ended only. Multiple choice questions for knowledge score, and then this the Likert scale questions on for attitude.
What is the importance of this was a new novel virus, so there was continuous changing knowledge. Like initially only keeping a hand was also allowed, and mask was not made compulsory. After it was made compulsory again, 2-ply mask and N95. So technical details are many technical details were there. So was this included in this questionnaire?
Yes, sir. There was a question about mask also, and most of them responded it in a correct way. That which type of mask gives best protection? This was one of the questions.
You have anything?
Ma'am, what about the validation of this questionnaire? How, from where?
Yes.
Yeah.
First of all, the questionnaire was prepared from on the basis of previous studies from CDC, WHO, and then this questionnaire was validated from 2 experts that were involved in the COVID management from the COVID care hospital of PGI. We sent the questionnaire to them and got it validated.
Okay, that's nice.
Thank you very much. We move to the next speaker.
Thank you. Thank you, sir. Thank you, everyone.
Who is the next speaker?
Next speaker.
Hello, sir. Good morning. I'm Dr. Shobha. I'll be sharing the screen.
Okay, Dr. Shah.
Dr. Shobha from Kolar?
Yes, sir.
Okay, please carry on.
Yeah, thank you. So, good morning, everybody. I'm Dr. Shobha from Department of Physiology, Devarajas Medical College, Kolar. I'll be presenting on a topic, heart rate variability, a simple tool to assist autonomic toning young adults at risk of developing type 2 diabetes mellitus. Type 2 diabetes is a non-communicable disease which has increased worldwide in epidemic proportions, especially among old age, as well as in younger age groups, sedentary and obese. Sympathovagal imbalance has been attributed as a primary pathophysiologic mechanism for the development of insulin resistance and type 2 diabetes mellitus. Indian diabetes risk score is a simple, cost-effective tool than oral glucose tolerance test for screening and diagnose type 2 diabetes in India. Indian diabetes risk score uses 4 parameters such as individual's age, gender, family history of diabetes, waist circumference, and physical activity to assess individual risk for developing diabetes. Studies done on diabetes showed reduced HRV with the duration of disease, hyperinsulinemia, obesity, hypertension, and retinopathy, and showed HRV as an independent risk factor for cardiovascular morbidity and mortality. The present study is aimed to investigate changes in cardiac autonomic modulation by measuring HRV among individuals with different levels for type 2 diabetes categorized based on IDRS. So the earlier studies that I've done are done mostly on the diabetic patients, and not many studies were done on the pre-diabetes or the people who are at risk of developing diabetes. So I've taken this study to see the autonomic modulation or the autonomic changes even before they become before they become the hyperglycemic or develop the type 2 diabetes. So hypothesis, young adults who are at risk of developing type 2 diabetes showed early autonomic imbalance. Objectives to determine IDRS and HRV among young adults aged 18 to 25 years to compare HRV parameters in low, moderate, and high risk groups in young adults. Material methods, this is an observational cross-sectional study. Total sample is calculated to be 150. Sampling was done by a randomized sampling. Study population includes healthy individuals in the age group of 18 to 24 years, and both males and females are included in the study. Coming to that, after taking ethical clearance and informed consent from the subjects, by considering the age and the age criteria and excluding the patients with any autonomic dysfunction or the people who are on drugs, all those things, we have collected the data. That the methodology includes, it is done under 2 steps. First, we have collected the demographic characteristics and anthropometric characteristics. Demographic characteristics like age, gender, education, family history of type 2 diabetes, and physical activity. And anthropometric characteristics like weight, height, waist circumference, hip circumference was measured. Body mass index, waist depression, waist height ratio was calculated. And the Indian diabetic risk score was estimated based upon the anthropometric data and the demographic data. IDRS categorizes the risk for type 2 diabetes as follows. That is, less than 30 is low risk, 35 to 50 is moderate risk, and those with more than 60 is considered as high risk. HRV was measured, that is continuous 5-minute ECG recorded was collected using HRV software, that is ID instrument. Time domain and frequency domain HRV parameters were recorded. Descriptive statistics and the one-way ANOVA test was done, and the post-hoc QK test was done to analyze the quantitative data, that is to compare between the 3 groups. Percentage distribution of the study subjects according to IDRS. In our study, we found that about 47% were categorized under low risk, and moderate 40% under moderate risk, and 30% under high risk based upon the Indian diabetes risk score. And this is the table showing the demographic characteristics of study population. Here, in high risk group, when compared to the mild and moderate risk group, high risk showed they weighed more and most significantly, and their BMI is increased when compared to moderate and mild, but it is within the normal range as per the WHO. Next table, this table compares the comparison of the basal heart rate and blood pressure among subjects with high risk group. This table is taken for recording the heart rate and the blood pressure parameters like systolic blood pressure, diastolic blood pressure, pulse pressure, and mean arterial pressure. This table, the SBP, DBP, and pulse pressure or mean arterial pressure is significantly increased. Increased in high group when compared with the moderate and the mild group. Even though it is a normal range, we can see it more in the people with high risk group when compared with the mild and moderate risk group. This table compares the heart rate variability at rest among subjects in high risk. This is mainly time domain parameters are compared. Here, the IDRS score is significantly increased in high risk group when compared with moderate and mild. And SDNN is also is increased in high group when compared to moderate and mild. Mean heart rate is though it is not significant, we can see that it is more in high risk group when compared with moderate and mild group. This table compares the frequency domain parameters of heart rate variability at rest among subjects in high risk group. Here, this table shows in a case of like in high risk group, the high frequency is decreased, and even the total power is decreased. And whereas LFHF ratio, which is tells about the balance, is increased in high risk group when compared with the moderate and the mild group. So summary of the results: HRV parameters, time domain, and the frequency domain parameters were analyzed in all the groups. In the high risk group subjects, HRV parameters that measures cardiac vagal functions such as total power and HF were significantly reduced, whereas LHF ratio, an indicator of sympathovagal balance, was significantly high when compared to low and medium risk group subjects. Increased mean HR, a marker of cardiac sympathetic activity, was high when compared to the low risk group. There should be a balance between 2 ANS branches for the normal functioning of the body. Increased LHFH ratio and decreased total power
Last 1 minute.
high risk group indicated an imbalance between the 2 systems, with sympathetic hyperactivity and vagal withdrawal in the high risk group. Increased sympathetic activation and reduced vagal tone for a long time in these individuals might result in abnormal glucose regulation, which may progress from the normoglycemia to pre-diabetes and diabetes status. Conclusion: from our study, it is evident that cardiac autonomic dysfunction by means of increased sympathetic and reduced parasympathetic activity occurs in high risk group. Thus, early identification of impaired HRV could be the first sign of autonomic dysfunction in subjects with high risk for the development of type 2 diabetes. With appropriate lifestyle modification, both the reduced HRV and risk factors for diabetes according to IDRS can be reversed. limitations, biochemical parameters could not be assessed because of the funding constraints, and the sample size can be increased to have them better knowledge about this in type 2 diabetes. And these are my references. Thank you.
Hello, Dr. Shobha.
Hello, thank you. Yeah, I finished.
Yeah, Dr. Shobha, what were the exclusion criteria, inclusion, exclusion?
Ma'am, inclusion criteria is age between 18 to 25 years and both the gender. There should be like exclusion criteria, those who have any family history of hypertension or any abnormality in endocrine disorders, any thyroid, or any medications if they're excluded from the study.
Okay, so now I'll just open it for all the participants.
I have one question.
Okay.
Dr. Shobha. Dr.
Yes,
Shobha.
sir. Yes, sir. I can hear you, sir.
Yeah, you have used tables and you have not explained the abbreviations. A fellow like me cannot understand the autonomic function. So how do I read?
Sir, I didn't get your question, sir. Can you please, sir?
The tables you have used, abbreviations, those are not explained in the footnote.
Yes, sir.
And also you have a constraint of analyzing fasting blood sugar for financial.
Yes, sir.
problem.
Yes, sir.
Fasting
Yes, sir.
blood sugar will not cost much, you know. That's not a restraint.
Actually, sir, in our college, we need to go for our internal funding, sir. So actually, the next part of the study will be that only, sir.
But most of them have their values. You could have collected from them.
So because I have taken most of the students, sir, 18 to 24 years, in the undergraduate medical students I have taken.
Yeah, medical college can do blood sugar free of cost.
Yes, sir. I will do it, sir.
Okay, thank you.
As you have not measured the blood glucose, so is HRV a cause or effect of diabetes? Means it may is it the cause or it is the effect of the natural history of diabetes? Because FBS was not measured.
Yes, sir. Sir, HRV may lead to insulin resistance, and so that the person may develop the type 2 diabetes. It may be a cause also, sir.
Any questions?
Okay. If there is no other questions, we can proceed to the next presenter, Dr. Nikita Parmar from GMC Bhavnagar. Thank you, Dr. Shobha, for presenting.
GMC is Government Medical College or Gandhi Medical College? Right. Sometimes I confuse.
So good morning to all respected faculties. Myself, Dr. Nikita Parmar. I am postgraduate student. I am from Government Medical College, Bhavnagar, Gujarat. So today I am presenting a topic on effect of menopause on arterial stiffness in middle-aged Gujarati women. So to introduce with, menopause is a physiological factor that affects the cardiovascular health in midlife women. It is studied mainly in terms of blood pressure, brachial blood pressure, which has its own limitation. Arterial stiffness is affected early in cardiovascular aging, and it is actually happens before actual hypertension. So we measure the arterial stiffness with the help of pulse wave analysis, which is a non-invasive, validated, and objective test to measure the parameters of arterial stiffness. So we have two parameters like pulse wave velocity, which measures the central arterial stiffness, and augmentation index, which will measure the systemic arterial stiffness. Both will increase with the age and arterial stiffness. So in normal aortic pulse wave, we can see the forwarded wave and one which comes a reflected wave, which comes from periphery. In cases of arterial stiffness, we can see on the right side that the reflected waves will come early and with higher volumes, which will increase the pressure, which is known as the augmentation pressure. You can see the difference between two graphs. So earlier we have published the mobilograph based pulse wave analysis normative studies of these parameters in our population, and we have observed that male has disadvantage that turns to female disadvantage after middle age, after 45 years of age. So menopause could be one contributor responsible for the same. So we set out to test menopause and arterial stiffness relationship using the same protocol and instrument. So we aim to compare measures of arterial stiffness derived by pulse wave analysis in middle-aged female with or without menopause. So how we proceed? First, we took the permission from Institutional Review Board and Ethics Committee. Then for our cross-sectional study, we enrolled 134 subjects after taking their written informed consent, and we have divided into equal parts 67 premenopausal and postmenopausal. So we have used this instrument, which is known as mobilograph, which is developed by IEM company Germany, and it is certified by European Society of Hypertension, which has normal Riva-Rocchi cuff, which has 4 size cuff. We can use it according to the mid-arm circumference, which is one tubing, recorder, and one holder. So this method includes the oscillometric principle. So in this method, what will happen? First, we will tie the cuff on our left arm. Then for first reading, it will take the pulse, brachial pulse, pressure pulse. Okay, they will record for 10 seconds. After 30 minutes of pause, they will do second reading. And in this second reading, during deflation at the brachial diastolic pressure, the cuff will remain inflated, which will generate the oscillation. So this brachial oscillation pressure, it will be converted into the aortic pressure changes with the help of this GTF arc solver, which will give us the aortic pulse pressure, which will be direct. So in our study, this is our baseline data. So we can see that in postmenopausal age group, we have less physical activity, heart rate were comparable. We can see that all the arterial stiffness parameters has increased with the age, but only aortic pulse wave velocity has a significant difference. So in discussion, we can say that the groups were comparable for BMI and heart rate. Postmenopausal group had higher age and brachial blood pressure, and postmenopausal group had higher augmentation pressure, aortic pulse wave velocity, but has comparable augmentation index. Only aortic pulse wave velocity showed significant, statistically significant. So what does it mean? Aortic pulse wave velocity, which describes the central arterial stiffness, which has altered, but the augmentation index, which shows the peripheral arterial stiffness, has not much altered. So for vascular progeria that affects the aorta, which will cause the increase in cardiac workload, which may produce the cardiovascular diseases in later ages. So what can be the causes? So first is loss of hormonal support in postmenopausal age group, increase, which will causes the vascular progeria, and it will lead to increased blood pressure and other cardiovascular diseases. These are some supportive study, but they have used the regional pulse wave analysis rather than direct. And these study groups were elder than our case group, and they use tonometry instead of oscillometry method. So aortic pulse wave velocity has altered, but not the augmentation index. Okay. So to conclude with, In women during menopausal transition, there is accelerated vascular aging, which is indicated by raised aortic stiffness and which is associated with age and blood pressure. Our study needs further study to reinforce our results. Limitation of our study was the cause-effect relationship cannot be established because ours was cross-sectional study. We need vertical follow-up. We can do some future studies based on ours. Pre-menopause and post-menopausal vertical follow-up study, effect of HRT, effect of lifestyle modification, effect of early menopause in cases with hysterectomy. So these are our references. Thank you.
Thank you, Dr. Nikita,
Thank
for
you, sir.
presenting your work. This is your postgraduate work.
Sorry.
This is your MD work.
Yes, sir.
Okay. I have 2-3 questions. What are the cutoff age group?
Sir, for
These are
so one
menopausal
minute.
women. So what are
Yes.
the cutoff age group? You don't have to look at the
45 to 65 years.
in your study.
Yes.
Okay. Then we have you have shown a lot of references, but you have not presented your review of literature. I want to ask you, there are no similar studies available regarding arterial stiffness in menopausal women?
Not with the oscillometric method, sir.
That you should mention in the review.
Okay.
We have not done that.
Okay,
At the
sir.
end, you have a list of references.
Yes.
And what is special about your title contains Gujarati women?
Yeah.
What is special about Gujarati women? Makes no relationship with the study.
Yes, definitely. But the demographic data, environment can affect our BMI
But
and
you said Gujarati,
yes,
not
sir.
Gujarat.
Yeah.
And also you have mentioned physical activity. And you have a score or something like that. How did you assess physical activity?
Based on sedentary lifestyles or more than
Is there any method to assess physical activity?
sorry, sir, I don't know.
फिर कैसे पूछा क्या? How did you find out the results?
Sir, we ask about that more than 8 hours of physical activity during daytime.
Nobody is doing 8 hours of physical activity.
There are criteria for assessment of physical activity also.
Yes,
Should have
sir.
included.
Okay.
And
Yes,
how many total candidates you have taken?
341, ma'am.
345.
Hmm.
Any questions from the audience? Please.
Will you distinguish between as itself will cause the changes in stiffness? So how will you distinguish between that?
Yeah, who is asking this question? Can you just introduce yourself, please?
I am Dr. Khan speaking. So if the age is increasing, then there will be increased stiffness. And whether it is due to increased age or post withdrawal of hormones, hormonal changes.
Sorry, I didn't get it. Your voice was interrupted.
Age is increasing. That is in the postmenopausal age and effect of hormones. Whether the hormone is the cause or age is the cause.
You can ask the question in chat box.
Before the chat box, we can take up this question.
Yes. Yes, sir. So tonometry will measure the pulse wave analysis between two regions of aorta, and this oscillometric method will measure the direct aorta pulse wave velocity. So we have one article which supports which says that oscillometric method is superior than tonometry method. oscillometric method with the help of mobilograph, which is developed by IEM company from Germany. Mid-arm, yes, sir. Just like our normal BP cuff, sir.
Chat box has appeared.
Okay, thank you.
Thank you, sir.
Okay. Sure.
The question Dr. Kedar Khanke has asked is how to distinguish between effect of age and on PWV versus hormonal changes on PWV, because age is more in post-menopausal age group. And can you take male elderly for comparison?
So actually, we have done one normative study, which shows that there is one gender difference. After the age of 45 years, female is having more pulse wave velocity than male, which so we can justify it by these menopausal effect because of decrease of hormonal support. So we can say that there is some role of menopause, and there is the role of gender.
Is there any study on males also? Have you found any studies? I mean, you're talking like oscillatory method is you're using for the first time.
No, we have done 3 or 4 studies, ma'am. One normative study, one in menopause, one on hypertensive and diabetic as well.
Okay, so all in, and the candidates were?
Patients, ma'am. I have included normal healthy women.
Okay, first is
Yes.
normal healthy. In
Yes. Hypertensive.
age,
I have took for postmenopausal 45 to 65 years.
okay.
Yes.
We have any more speaker?
It is a menopausal transition age, sir. We can justify like that. Menopausal transition. Yes, it will be called as early menopause.
Thank you, Dr. Nikita. We have any more
other
speakers
speaker?
in this session? No. Yeah, one more.
Thank you. Thank you, sir.
Thank you.
Thank you, Doctor.
Offline. I request the judges and the audience to please restrict the number of questions to 2, be it offline or online mode combined.
Okay, so Dr. Salim Sheikh from ESI Faridabad, the next speaker.
Welcome all. Thank you for giving me the opportunity. Thank you for giving me the opportunity. The title for my paper is Antibiotic Point Prevalence Survey at Tertiary Healthcare Hospital in India, identifying strategies to improve the antibiotic stewardship program immediately after a COVID-19 wave. I will be the presenting author. The credit other authors were my professor and head. Dr. Monica Agarwal supervised and validated the process. Girish sir was involved in writing the original draft and reviewing the article. Gopal and Sharvanti and Pooja were senior residents. They helped with investigation and data curation. Gopal, in addition, assisted me in formal analysis. So with introduction, antimicrobial resistance is the top 10 threats according to the Global Health, WHO. It is estimated that by 2050, it will be the first or the major cause of death due to the antimicrobial resistance. The COVID pandemic has caused 2 major things regarding to ASP, the antibiotic stewardship program. It caused a massive upsurge of use of antibiotics due to fear, unknown fear, and derailment of antibiotic stewardship program. In addition, there is a lack of national registry for antimicrobial consumption in India. We conducted a point prevalence survey, which is a validated method by WHO 2019 guidelines. And we used the WHO aware list, that is A for assess, WA for watch, and RE for restricted list of antibiotics. Aims and objective. The objective was to identify the antibiotic prescription pattern in a hospital. Secondly, to explore the factors influencing the choice of antibiotics. And third is to develop the strategies to improve antibiotic stewardship program with ultimate goal of to help national bodies for formulation of guidelines for promoting rational pharmacotherapeutics for antibiotics. Methodology. The study was started after getting a ethical clearance with this letter. The ethical code followed in the study was the ICMR guidelines for biomedical research on human participants, updated 2017. Our study was a single center cross-sectional point prevalence study. It was a non-funded study, and the period was for 4 weeks, extending from 15 September to 14th October 2019. The methodology, the particular day or ward for data collection was decided by a lottery method due to restraint of the manpower. So inclusion criteria was basically admitted patients in the ward or ICU before 8 a.m. on the intended day of the surgery. It is as per the global PPS guidelines by the WHO. And exclusion criteria were the patient who were admitted after AM on that day, outpatient and emergency department patients, and patient intended to be discharged on the very day of the survey. Parameters we estimated or calculated were the number of patients prescribed on antimicrobials. Secondly, categorization of the antimicrobial prescriptions. Then categorization of the antimicrobial prescriptions based on the indication and number of patients on designated antimicrobial. Designated antimicrobials are a special class of antibiotics which are reserved for higher infections. So data was collected in the case record forms and was entered into the Microsoft Excel to 2010. The statistical calculation was done using the SPSS version 26.0, IBM Corporation, USA. Now coming to the observation and results. So firstly, this figure is showing the percentage of patients on antimicrobials in different wards. So as expected, it should be more in the ICU, but we found out it was more in the obstetric and gynecology department. It made us think why it is more into OBG. So this is the beauty of these results, that we tend to find out certain things which are out of our prejudged mind. So it will help in effectiveness of the policy, identifying targets, specifically area of quality improvement, and informing the policymaker or hospital administration in our case for improvement or channelizing the antibiotics. Now the second parameter was average use of antibiotic per patient. It was around 1.78 with a standard deviation of 0.8. A pre-COVID PPS study averaged it to be 1.62. So it was a little bit higher in our hospital. Maybe the carryover phase of COVID-19 was a cause of this overuse of antibiotic. Coming to the categories of antimicrobial as per the investigation, this is a very important aspect: empirical, prophylactic, or lab-based. And we found that it is on the lab base, which is very important. It was only around 8%, which is below the average, which is ranged in the major part of India. Most of the antibiotics were given empirically, but actually they were used as a prophylactically on getting into more details. So this was, we found out, and maybe this was due to the reviving, this initiated or compelled to think that we have to revive the habit among clinicians to send culture reports and utilize culture reports. The main thing we were missing were there were no lab reports. It was all conveyed through telephonic in spite of very good infrastructure, which is not good. anything which is not documented is meant it is not done. So now coming to next thing was route of antimicrobial therapy. So mostly parenteral were prescribed as expected. It is proper belief that it is parenteral route is more superior or more effective, but it is not the case
So
always.
last 1 minute.
So during the next is about designated antibiotics. So see, there is a increased carbapenem use. Antibiotic prescription indications, most important was unknown cause without any lab-based and any justification, followed by community acquired infection and other things. These were the breakup of all the antibiotics. Majority was used by third generation cephalosporin, ceftriaxone, easily available, and other was second number was imidazole group, metronidazole. On conclusion, we find some strategy which can help us improving surgical prophylaxis guideline for surgeons, training residents to categorize antibiotic prescription appropriately, decreasing the prescription with double anaerobic covers, reviving the culture of sending culture reports, and improving the electronic medical record for improving prescription auditing. For future research and direction, there is a need for confluence of health experts along with health data, whatever is generated. So pre-COVID data, we are already working on that. Multi-center approach is required. Plus national portal is required for uploading of all the AMR data, and role of electronic medical records is very essential. And at last, I will close my presentation with telling that filling whatever gaps with the gaps is a good antibiotic prescribing practices, which we have to teach to our undergraduate students from the second year onwards in the early clinical exposure. And I will acknowledge my nursing staff, resident and consultants of all the respective ward and ICU for helping our team achieve this article. Thank you all.
Sir, what was the study duration from?
15 September to October 2019.
19. It was pre-COVID time.
Post-COVID, after major in the July.
19.
Yeah. Sorry, madam. 21. 21.
Okay.
21.
That's what.
21.
No, it is
21.
reflecting 19 everywhere.
Okay.
So that's why I got confused. It is
21.
pre. You are talking about post. Okay. So questions from the audience. Sir.
Thank you, Dr. Salim, for bringing out the study. Which department used minimum?
Sir, psychiatric and ophthalmology, sir, zero.
Psychiatry में क्या करेगा फिर भी? Obvious.
फिर भी, sir, we have to, as per PPS survey, we have.
What was the reason the obs and gynec department were using maximum?
Sir, there is also.
They were unnecessarily using, or there was some need?
They maybe patients were more during COVID-19. More of obs-gynae patients were there, I think so. Is it?
Patient or ma'am,
other
because
patients were less, I think surgery and all things were not there during COVID time.
ma'am, most of the females, the gynec side, I am not a clinician, but we found that pelvic inflammatory disease is a assistant complaint. So they are taking this antibiotic.
That's fine.
So,
any questions from the audience?
What is the role of empirical antibiotic therapy, and how much time does it take for the culture report and antibiotic sensitivity to come?
culture reports in present day depends. We are doing blood culture over 2 to 5 days. It start coming after 1 day only, 24 hours. It keeps on. If there is any growth, it has been informed by the respective microbiologist and the report is sent. So it takes 1 to 2 days at the max for these reports to come. And empirical is mostly a misnomer because people are using prophylactically drugs as empirical without suspecting that there is a likely cause of infection, which may not be there. So, and plus there is additional pressure, especially the medical legal aspect of being sued by the patient if not prescribed the proper antibiotic. So that is always in the back end of a doctor while prescribing. So that.
One more thing.
Yes.
You mentioned more parenteral use and less use in ICU. How do you correlate these two?
No, sir, less in the ICU was not less. ICU was the
Yeah, you said
second
your
topper.
graph shows less use in ICU antibiotic.
It's second, sir. It was second topper, so 58%.
And parenteral use was maximum.
Yeah, sir, 81% around.
How do you correlate that? Normally, oral use is maximum
In the ward, sir.
in the wards.
Yeah, in the ward, basically, it is a common practice, maybe not evidence, but the learning base that two drugs are always started: injection ceftriaxone, injection metronidazole, and sometimes injection amikacin 5 is.
Yeah, that's related to gynecology.
Right.
You're talking about
This
metronidazole.
metronidazole. So that was the thing, sir. We have to be on more of evidence-based medicine, and so with collective efforts, we can achieve that things. It is a very long process.
Metronidazole used as antibiotic.
Sir, it is used as a mostly in the PIDs and antimicrobial agents. Sir. Post, yes, sir. Yes, sir. And there is one more point, sir, because majority of patients were also referred. That was our hospital is a referral.
Delivery purpose or cesarean purposes.
Yeah,
For
sir.
that only we have to use it.
It
And
was-
during that time, antibiotic was a little higher use because we did not know whether the effect of coronavirus will be what this with the body immunity. That's the reason. Sir. And
Yes.
large number of patients are only obstetric patient was there, not the
Referred.
gynae patients, and other surgical field was almost suspended working.
Dedicated.
That's why Madam said more number of patients here. That was the correlation.
Okay, thank you, Dr. Salim
Thank
Sheikh,
you,
for
ma'am.
a nice presentation and a lot of things to be discussed about this.
Thank you, ma'am.
It's a
Thank you,
very
sir.
interesting topic.
Yes, sir. Thank you, judges, and congratulations to all the participants for such an informative session. Now I request judges to please give certificate of participation to all the candidates. I invite the judges to be present on the stage. Dr. Shobha MV. Dr. Shobha MV. Dr. Sangeeta Bhavra. Dr. Nikita Parmar. Dr. Nikita is here. Dr. Nitika Parmar. Dr. Salim Sheikh. The participants who participated by the virtual online media, the certificate will be transported to them via email. It will be sent to them via email. Thank you, judges. Congratulations to the participants once again. We now move forward to our next symposium. We request Dr. Pandey to please felicitate our judges for the session. We request Dr. S.K. Vajpayee to please be present on the stage to felicitate the judges. Thank you, judges. We now move forward up towards our next session, Symposia number 9, titled Molecular Genetics and Genetic Disorders. The chairpersons for the same session will be Dr. Mandal from ESIC Medical College, Faridabad, Dr. Brigadier Tathagat Chatterjee from ESIC Medical College, Faridabad. I request the chairpersons to please chair the session. The speakers for the session will be Dr. Madhulika Kabra from AIIMS, New Delhi, and Dr. Sanjeeva K from Bengaluru. The third chairperson for the event will be Dr. Parveen Guliani Chaudhary, MS Ma'am, ESIC Medical College, Faridabad. We have 3 chairpersons for the session.
चल जाएगा वीडियो ना होपफुली चल जाए बिकॉज़ आपने हाइपरलिंक तो नहीं किया नहीं ऐसे नहीं Shall I begin, sir? Okay, right. Shall I begin, sir?
I'll introduce you. Professor Madhulika Kabra is a leading genetist of this country. She is a very senior professor of genetics there. And she has been heading the genetics department in the Department of Pediatrics for a very long time. I think after Dr. I.C. Burma left, she has been there. I'm proud to say that we have been working together as a colleague sometime around 35 years back. She has a lot of work in the field of genetics. She has a lot of publications, and she is an excellent speaker. You will really enjoy her speech. And through her speeches, she has been spreading the information about the genetics. She not only information, she actually helped us a lot when I started establishing the genetics unit at Maulana Medical College. And she has contributed a lot. Dr. Seema Kapoor was assigned that she was with me. She has a special interest in the field of intellectual disability, storage disorders, newborn screening, dysmorphology, mutation, and many others. She has numerous publications. I'll invite Professor Madhulika to deliver her talk. Thank you.
Thank you very much, sir, for your kind introduction. I would like to thank the organizers for inviting me here and interacting with you on lysosomal storage disorders with a special focus on Gaucher disease. The conference is on physiology and pharmacology, and I guess I'm here because the theme is confluence of health sciences. I hope there are some clinicians and pediatricians in the audience here and virtually, because a large part of my talk is going to be clinical. So the learning objectives or the plan of presentation for this particular session would be, I'll be giving you an overview of the lysosomal storage disorders, when to suspect Gaucher disease because the focus is on Gaucher, what are the diagnostic testing and pitfalls in Gaucher disease, what workup we need to do in patients with Gaucher, and about the treatment of Gaucher disease also. Now, just talking about the prevalence of lysosomal storage disorders, collectively it is quite high. So I think for pediatricians in the present era, it is important to know about rare diseases. You must be hearing a lot about rare diseases, the rare disease policy being declared in March 21, many court cases going on, many parent organizations fighting for their treatment of their children. So I think for pediatricians, it's the right time to learn about rare diseases. And I think lysosomal storage disorders are the disorders which the pediatricians are very likely to see in their clinical practice. So overall, the prevalence is high, though individually these may be rare, and we do not have prevalence data from our country. But considering the high rates and consanguinity, it is just an extrapolation from the Western data that we may be getting about 3,000 new cases every year. So about 50 lysosomal storage disorders are known. So this is a collective figure. And as you will be learning, and you must be knowing that many of these are treatable. So about 500 children are born affected by treatable LSDs every year. And needless to say that it is important to make an early diagnosis if you want to treat these children and prevent the complications. So basically, it's a group of lysosomal storage disorders. This includes 50 disorders. And in simple words, it is caused because of the accumulation of substrates in the cell lysosomes. And this could be because of the deficient lysosomal enzyme or a receptor target abnormality in the activator protein, membrane protein, or the transporter. So ultimately, with any of these defects, what happens is that instead of the normal metabolism of these substrates in the lysosomes, these get accumulated in the lysosomes. And because lysosomes are there almost everywhere in the body, most of these disorders are multi-system disorders. We need to remember that lysosomal storage disorders are progressive disorders, and treatment is available for few of them. And if treatment is started early, some features are reversible, but otherwise most of them would progress, and multi-organ involvement is there in most of the cases. These are the common lysosomal storage disorders which we see in clinical practice, and Gaucher disease is probably the commonest worldwide also, and probably in India. This is just based on experience because we do not have epidemiological data. The other disorders which we see are MPS 2, MPS 1, 4, and MPS 3. Others include metachromatic leukodystrophy, Niemann-Pick disease, Tay-Sachs, and GM1 gangliosidosis. Neuronal ceroid lipofuscinosis is supposed to be one of the very common neurodegenerative disorders. Maybe we are missing it. Pompe's and Fabry's, and many more. Now, inheritance of most of these disorders is autosomal recessive, which means that both the partners are carrier, and the risk of recurrence would be 25% in each subsequent pregnancy. Fabry and Hunter disease are X-linked recessive, which means that if the mother is a carrier, there's a 50% chance of the male offspring being affected. Now, the clinical features of the lysosomal storage disorders are very, very heterogeneous. But for pediatricians, I think we need to remember that as the phenotype is diverse, we need to have a very high index of suspicion. The age of onset is variable, may be intrauterine. Some of these patients may present as hydrops fetalis, and later on at any age, even an adult or elderly, you may find some patients with something like Gaucher disease. And most of these would present in the pediatric age group, infantile to the childhood age group. Anemia and bleeding, which is unexplained with organomegaly as an important feature of Gaucher disease. Coarse facial features, you are aware, for mucopolysaccharidosis. Corneal clouding are again for mucopolysaccharidosis. Organomegaly is common for many. Hernias for mucopolysaccharidosis. Arthropathy is again an important feature of mucopolysaccharidosis. And neurological features, which can be very, very heterogeneous, are also important, very, very important feature. So these are just to show you some of the phenotypes. This is mucopolysaccharidosis phenotypes, and these 4 pictures in the beginning are variable spectrum of mucopolysaccharidosis type 1. And as I said earlier, the phenotypic spectrum is very variable, being from very mild to very severe phenotype for almost all lysosomal storage disorder. The boy which you see here is a case of Hunter syndrome, where you have no corneal clouding. This is X-linked disorder. This is a child with MPS 4, and this is MPS 6. And this girl is actually a case of MPS 3, where the diagnosis is actually difficult because primarily these children would present with neurological features, hyperactivity, behavioral problems. You can appreciate mild coarsening here, and you may not have many other features of MPS. Now, these are the other features which may make you suspect lysosomal storage disorders. Is gibbous, multiple Mongolian spots, which is a common feature of severe form of MPS 1 and GM1 gangliosidosis. This is hernia, corneal clouding, squint typically seen in neuronopathic Gaucher, and an enlarged head, which you see in Tay-Sachs disease. Fabry disease is another lysosomal storage disorder, which is again at times difficult and difficult diagnosis, as it can affect many parts of the body. Typically, you may see mild coarseness of faces, renal involvement, and a typical rash, which we call as these are the petechial-like rashes, which you see typically around the umbilicus in Fabry disease. Pompe disease is another treatable lysosomal storage disorder, which again varies from a very severe infantile form and to a late childhood form or a juvenile form. And if not treated, the infantile form children would die very early because they have severe cardiac involvement and muscle involvement, and would usually die of either cardiac failure or respiratory failure and have repeated infections as well. The levels of the enzymes would vary depending on the severity of the disorder. Now, this is just very brief about the commoner lysosomal storage disorders, and this is just to tell you that there are various therapies which are now available for lysosomal storage disorders. And as we understood the pathophysiology, where the whole pathophysiology actually rests on the accumulation of these substrate in the lysosomes, some way or the other we have to either enhance the enzyme, give the enzyme by enzyme replacement therapy, or reduce the substrate so that less enzyme which is available can act on the substrate which has been reduced. Chaperone therapy, which we will be just discussing a little bit, gene therapy, which has actually come up. And then for some of the disorders, hematopoietic stem cell transplantation is also in use. Now, if we talk of therapeutic approaches to lysosomal storage disorders, we need to keep in mind that most of these are not curative. If we are giving enzyme replacement therapy, it has to be lifelong. HSCT for certain situations will be curative, but it has its own problems. And other thing which we need to remember also is that there's a variation in response to therapy as well. It would depend on the severity and at which stage the treatment has been started. So the response is not uniform. And in certain situations, in fact, why the child is not responding well is not very, very clear. So we need to keep in mind that even if a specific therapy is not available, a multidisciplinary supportive care is the basis of treatment, irrespective of the fact that we have a specific therapy or we do not have a specific therapy. So enzyme replacement therapy, which is available for a good number of lysosomal storage disorders now, and many patients in India are getting this therapy on compassionate access program or through reimbursement. And many of the patients, I'm really happy, that are getting through the ESI as well. The cost is very high. And just to give you an idea, in general, the cost varies though. For say a 10 kg child, the cost may be somewhere around 50 lakhs per year, and it would increase with age. Another important thing which we need to remember about enzyme replacement therapy is that it does not cross the blood-brain barrier. So the neurological features are not improved. And again, needless to say, early diagnosis and initiation of therapy is important. So this is the list of disorders for which enzyme replacement therapy is available. Substrate reduction therapy is also available for Gaucher. So you have Gaucher, that was the first one. And I would like to emphasize the best response to enzyme replacement therapy is in Gaucher disease, particularly type 1. Pompe disease, Fabry, several types of mucopolysaccharidosis, which include MPS 1, 2, 4, 6, and 7, Wolman disease, and neuronal ceroid lipofuscinosis type 2. Very recently, a compassionate access program for enzyme replacement therapy for Niemann-Pick disease has also come in, though it has not been approved as of now in general use, but this has also come in. Now, just to touch upon gene therapy, because it is, you must be aware that gene therapy is coming in, which we never thought that it would come in such a big way. For spinal muscular atrophy, it has recently come in, it's really effective. So even in lysosomal storage disorder, gene therapy is being worked on for many. And very recently, metachromatic leukodystrophy, which is a lysosomal storage disorder, gene therapy has been approved, and the study which has come initially seems to be very promising. Now, with this brief background and introduction to lysosomal storage disorders, I would now switch on to Gaucher disease, which is caused by mutations in the gene GBA1, which encodes for the enzyme lysosomal glucocerebrosidase. And as I've already said, in the absence of this enzyme, there is accumulation of the substrate in multiple organs. And as I said, there's a spectrum of severity, but traditionally there are 3 subtypes, which we'll just see. And according to the Western literature, type 1 is probably the most common. But in our country, as per experience, again, we do not have epidemiological data, probably type 3 is more common. So the common case scenario as pediatricians, which you would see and should suspect Gaucher disease, would be a child, say 5 years old, having weight loss and progressive abdominal distension for the last 6 months, increasing pallor and history of receiving transfusions. On examination, you find that there is significant pallor and there is significant hepatosplenomegaly, and rest of the systems are normal. You may or may not have neurological manifestations, and on evaluation, you find that there is decrease in hemoglobin and platelets, and ultrasound abdomen shows hepatosplenomegaly, and the other investigations like peripheral smear and the HPLC and workup for portal hypertension being normal. So in this situation, you should definitely think in terms of Gaucher disease. So these are the differential diagnoses for other storage disorder when you are suspecting Gaucher. So we have talked about Gaucher. As against Gaucher, Niemann-Pick disease, patients may not require frequent transfusions, but may present with significant pulmonary involvement and liver dysfunction. And again, they can present with massive splenohepatomegaly. And a very important sign which you should look for is a macular cherry red spot. Then other differentials include the LAL deficiency or the Wolman disease. You should also think in terms of mucopolysaccharidosis, which is clearly distinguishable because of the phenotype. And then another important differential is saposin C deficiency, in which actually you have the activator protein beta glucosidase deficiency. And here the neurological features are much more common. And similarly, the Niemann-Pick disease type C, which is actually a cholesterol transport defect. And again, they do not have significant organomegaly or transfusion requirements, but neurological features are more common. So these are the common manifestations of Gaucher disease, and you can see they are multi-system involvement. These are some general problems which these patients have, and you can see that hepatosplenomegaly are important features. Skeletal features are important. They can have fractures, anemia, thrombocytopenia, and neurological manifestations which are there in many of these patients. So as I was saying, there's a spectrum of the manifestations, starting from the most severe phenotype of hydrops fetalis to the phenotypes which we see in pediatric practice, or totally asymptomatic or just incidentally diagnosed. So these are the 3 types of Gaucher disease which I was referring to. So type 1 is classically called non-neuronopathic, where you only have splenohepatomegaly, skeletal disease, pulmonary disease, anemia, and thrombocytopenia, and supposed to be most common in the Western world. Type 2 is the most severe form and is the rarest also. These children would not survive beyond 2 years of age and have hepatosplenomegaly, anemia, thrombocytopenia, very significant neurological features and bulbar involvement, so they do not survive. Then type 3, probably being common in our country, again has 3 subtypes, and type 3A being the most severe, then type 3B, which we feel is probably common in India, which would present with other symptoms. In addition, they would have supranuclear gaze palsies and horizontal nystagmus. I'll be showing you a video on that. And type C has similar phenotype, but has cardiac involvement also. So probably we primarily have these 2, type 3B and type 1, and type 2 would usually succumb when we may be missing them. So these are the phenotypes of non-neuronopathic Gaucher disease, and you can see massive splenohepatomegaly, emaciation. You can see the skeletal involvement in the form of the spine involvement, and massive splenohepatomegaly in a very young infant also. When we talk of Gaucher disease type 2 and 3, which is neuronopathic form, there is developmental regression. And again, the neurological features would also vary, varying from very severe manifestations like here, as I mentioned in type 3A, to minor manifestations like abnormal eye movements and oculomotor apraxia. And these are some of the other patients. This is type 2 Gaucher patient. You can appreciate the opistotonic posturing because of and they have feeding difficulties, die very early. This again a neuronopathic Gaucher. This child is a milder form of neuronopathic Gaucher disease and has got significant pulmonary involvement and is on enzyme replacement therapy. Now, this is a girl who has been recently enrolled in a trial. You can see the massive emaciation, the hepatomegaly and the huge splenomegaly here. And this video actually shows you, video is not working, it seems. Okay, this video was actually for showing you the oculomotor apraxia. Can you do something about it? Can I open from the, I can open from the, Gaucher disease, ESI, right.
This is the group.
No, this, I don't know, just a video. I can run it. Okay, so this is slightly tilted. So this is how we look for oculomotor apraxia. So what you see here is that when the child is trying to look at an object, the child has to turn the head. The child cannot move the eyes without turning the head. So this is called oculomotor apraxia. Okay. So this is a very important feature, and if it is mild, it can be missed. So we need to sort of evaluate these children clinically, because the response to therapy, and if it's a severe neuronopathic form, then the treatment response may not be very good. So going on to the diagnosis of Gaucher disease, as I said, enzyme assay is the first thing which we do. Bone marrow aspiration is not being done very routinely these days, being invasive, but still in certain situations we have to do it. Biomarkers and molecular genetic testing and other tests. So enzyme assay is still the gold standard and usually being done in the leukocytes or mononuclear cells. And the residual enzyme activity, which is taken as deficient, is around 10% of the normal. And the lab range would vary from lab to lab. And it can be done on dried blood spots also. So that's a good thing. You can transport the sample very easily from one place to the other, because when you transport EDTA sample in a very hot weather, the leukocytes might sort of get bad and you may not get good results because of that. So we need to remember that when we are using enzyme deficiency as a diagnostic modality, it is only useful for the affected children. It is not useful for picking up the carriers, because the levels of carriers would actually overlap with the levels in the normal. So for carrier detection, we have to do molecular genetic studies only. Okay, sorry. Okay, sorry. So for detection of the carriers, we have to do molecular genetic studies always. And another important thing, whenever you are looking at the enzyme assay report, also look if the lab has also performed some control enzymes, because at times what can happen is that the protein content of the leukocytes which you have sent for the testing may be low itself, and that might be giving you a falsely low result. So ideally speaking, at least 4 to 5 control enzymes are to be done. In our lab, we do at least 2 control enzymes to say whether our assay is correct or no. Now coming to the biomarkers which are used for screening for Gaucher disease, there are many. Chitotriosidase we use in our lab, but the limitation here is that in some of the patients, the chito gene itself might be mutated and we may not be able to interpret it. CCL18 is another biomarker, but the best biomarker, which is not available presently in India, is lyso-Gb1. And here the requirement is of LC-MS-MS. The sensitivity and specificity of this particular biomarker is almost 100%. So biomarkers are important for screening, and also when you're treating these children, the levels of the biomarkers would come down. So it's a very, very important tool to monitor these patients. Bone marrow aspiration, I have just kept it here because it may not be positive every time, and you may not be able to differentiate the different kinds of cells. The classical description of the Gaucher cells and NPD cells is there, but at times it is done when the diagnosis is not clear, and as a part of routine diagnostic plan, you are offering bone marrow also. So coming to the molecular studies, this is GBA gene, which is on chromosome 1. And we need to remember that there's a highly homologous pseudogene sequence. So at times it may be difficult to amplify the true gene. So we have to be careful when we are doing the molecular studies. And there are more than 400 disease causing GBA mutations known. The first mutation reported was L444P, which is classically a mutation for neuronopathic Gaucher disease. And it is the most common mutation in India based on the studies done in our lab and in other labs also. This is the global data of around 430 patients. And you can see that this is the commonest mutation, which is N370S, which is a milder phenotype for type 1. The second common was L444P. Whereas in Indian studies, this is data from our lab, L444P is the commonest. And this is unpublished data again. So about 60-65% patients have L444P. And probably because of this, most of our patients have a neuronopathic phenotype. And this is another a publication from Gujarat, Dr. Sheth's lab. And here again, you can see that L444P is again around 60%. So usually the recommendation is in India that we do first L444P mutation because it is there in about 60% of cases, and then sequence the whole gene to look for other mutations. So just to summarize the investigations, so enzyme diagnosis is the gold standard. You can do it in EDTA blood, dried blood spot or fibroblast, not useful for carrier testing. Genotype is important, and we would always try to do it in the present era. Initial testing for this particular mutation, and genotype is important for prognostication, carrier testing, and prenatal diagnosis. And role of tissue biopsy is now very limited. At times, we make a retrospective diagnosis of a splenectomy is done on a child with Gaucher disease, and then we look at the histopathology of the spleen, a retrospective diagnosis of Gaucher disease is made. Now, other investigations which are important in Gaucher disease include CBC for looking for thrombocytopenia, anemia, and even leukopenia. Then they can have abnormalities of hemostasis also. So we need to work for hemostasis also. So we do coagulation studies also in these children. Radiological investigations include organ volumes. Most accurate by MRI, but ultrasonography can also be used. And the markers for bone health, which includes skeletal survey, the best one being bone mineral density using DEXA, and MRI spine and femur. And here you can see this is typical Erlenmeyer flask deformity, which has been described in Gaucher disease. Here you can see involvement of the vertebra, and here you can see involvement of the femur head, which is one of the important complications of Gaucher disease. Other investigations include bone markers, including vitamin D. We somehow find very low levels of vitamin D in Gaucher disease, and probably it is true for most chronic disorders, and some other investigations which are not routinely done. Antibodies for the enzyme is only done if we are planning to start enzyme replacement therapy. Now, coming on to the enzyme replacement therapy for Gaucher disease. So this is basically to artificially administer the recombinant enzyme. And these have been modified so that the targeted cells take up the enzyme very well. And the newer forms of the enzyme which are now being used have a very good penetration into the cells. Other modalities of treatment is hematopoietic stem cell transplantation, not recommended as of now for Gaucher disease because of the availability of enzyme replacement therapy. Still the treatment of choice for MPS type 1H, which is the most severe form of MPS 1. And these children, the treatment of choice is HSCT to be done before 2 years of age, before they develop complications. The substrate reduction therapy is again recommended for Gaucher disease and Niemann-Pick disease type C and Niemann-Pick disease type B. And here the drugs which have been approved are miglustat and eliglustat, which are used for Gaucher disease. And some of these are under investigation for Fabry disease. Chaperone therapy I referred to you earlier, which are the molecules which help the proteins to fold into their appropriate conformation, because some of the molecular defects underlying the LSDs, these are missense mutations and they affect the infolding of the protein. And these are the chaperones which help in folding of the protein, and they are being investigated for treatment for Gaucher disease. Now, the substrate reduction therapy, these are the two drugs which are being used. You can see this is eliglustat and miglustat. Most of the time now, eliglustat is being used, and this is an oral drug, but the cost is almost comparable to the IV preparations. Now, if you want to see the results so far for Gaucher disease is the Cochrane review for about 300 participants and 8 RCTs. And the conclusion was that at least during the first year of treatment, different enzyme replacement therapy drugs appeared to have a similar safety profile and all improve some of the most obvious manifestations of the disease. So, you know, there are 3 preparations available now for enzyme replacement therapy for Gaucher, and the results are almost similar. Now, this is a huge data set from international registry, and primarily this is based on treatment with imiglucerase. And here you can see they have followed up these children for 10 and 20 years, and they have found that there is a consistent improvement in the organ volumes, in the platelet count, in the hemoglobin parameters, and then they are stable over time. But obviously the enzyme replacement has to be continued, and same is true for the bone manifestations as well. Similarly, for type 3 Gaucher disease, though the neurological manifestations would not improve, you will see that after years of therapy, liver and spleen volumes are coming down, and same is true for the hematological parameters in the form of anemia and thrombocytopenia. So a little bit about the Indian experience of treatment with Gaucher disease. This was the first publication, multi-center publication for only 22 patients. The follow-up was only 6 months here, but it was found that there was significant improvement in hemoglobin and platelets and the organ volumes as well. So as of now, this is a little older figure. So at AIIMS, we have 56 patients overall of lysosomal storage disorders who are on treatment. Gaucher is probably the highest. This number has also increased now. So 29, both imiglucerase and velaglucerase, and now we have patients on trial for teliglucerase also, and primarily from compassionate access program. And this is the data on 16 patients who are non-splenectomized and follow up for almost like 5 years. And you can see there's improvement in hemoglobin, improvement in platelets, decrease in spleen and liver volume, and decrease in the biomarker chitotriosidase, which I was mentioning about. And this is, again, I think I'll not be able to show a video. This maybe I'll show in the end if time permits. This is a boy of type 1 Gaucher disease, and he performed in one of the meetings. And these are some of the patients. These are 2 SIBs who we have been treating from a very early life. And one of the girl is actually more severely affected and splenectomized. This is the boy, and he's grown up now. There was a small video here also when he speaks about he's an engineer now and doing very well. And this picture was shared by Dr. Shubha Phadke. And I think you cannot believe that this lady is a patient of Gaucher disease and is leading a normal family life with 2 children who are normal. So just for reference, I'll refer you to this publication of the Gaucher disease task force, first author being Dr. Ratnapuri. And this gives you the information about how to work up these patients of Gaucher disease and what are the indications of giving enzyme replacement therapy in Gaucher disease. So finally, about counseling and prenatal diagnosis, we know that the risk of recurrence for Gaucher disease will be 25%. Being an autosomal recessive disorder, we have to explain them the treatment options, definitive and symptomatic, and also about the cost of therapy. You know now that there is a rare disease policy in place, and there is an option of putting these patients who require enzyme replacement on a portal, rare disease portal. This is being worked on, and the funding is planned through the CSR and donations, but it is still, because it is under implementation. Prenatal diagnosis can be done by chorionic villus sampling or amniotic fluid by the genotype preferably. And we also do enzyme estimation in the CVS tissue, but preferably we would do both. So to conclude, lysosomal storage disorders are commonly seen in clinical practice. Gaucher disease is probably the commonest LSD in India. We need to have a high index suspicion because the phenotype may mimic other pediatric disorders, and the phenotype may be very, very variable. Need to have a specific diagnosis, and I am really happy to say that multiple centers in the country are now offering these diagnosis, and a dried blood spot can do for molecular testing also and enzyme testing also. And treatment options are promising and available, but we need to remember that the cost is still prohibitive, and we do not have a definite way by which government can support these patients, though it is being tried through the rare disease policy. And we have to explain the patients that supportive care is very important, and multidisciplinary approach is the key for managing these patients. But should never forget the preventive aspects, counseling the family so that we can prevent the birth of another affected child, so that we can take care of the children who are already born. So I would like to thank you for a patient hearing, and I'd like to acknowledge patients, families, physicians, team at my own center, and the humanitarian initiatives taken by Sanofi, Sanofi Genzyme, Takeda, because it's really helped many of our patients. Thank you very much, and we should all join hands to care for the rare. Thank you very much. If there's time, I can show one video. If there's no time, we can leave that. Doesn't matter. So sorry, I wanted to show a very nice dance by a Gaucher patient, but sorry, the video didn't work here. I'll be happy to answer any questions.
Screening test for
That
this.
was a wonderful presentation, Dr. Madhurika. And I have worked with Dr. Madhurika in the pediatric genetics unit way back in 2001. But that time we were working on hemophilia and SNPs and VNTRs. Nice, quaint little hospital, little department where the space is a big issue, but the work is phenomenal. We have in the last 2 or 3 years at Army Hospital and AFMC diagnosed a few cases of adult Gauchers. What is your comment on adult Gauchers and how they actually differ from the type 1 infantile Gauchers?
Okay. So somehow in our country, maybe we are missing. We have more of, and as I said, probably neuronopathic is more common. That's why they present early. Adult Gaucher, we have few patients, and the primary manifestation could be anemia and some splenomegaly and bone disease. I think that's common. And I think we need to evaluate adults also for Gaucher disease if we have unexplained anemia, even without organomegaly, and if there is bone involvement, particularly osteopenia. So this is important. So recently we diagnosed a SIB of a child who actually has type 1 Gaucher disease, and it was doing well on enzyme replacement and now on substrate reduction. And the sister was incidentally diagnosed because she had some anemia which was unexplained. And when I examined her, she had a small spleen also and bone disease. So in adults, it may be difficult unless we really suspect it. So it is important.
Interestingly, Ratnadu and I are batchmates.
Okay.
You have been
right.
presenting. We were in
Yes.
AFMC together, and we keep communicating.
Okay.
And we recently presented Gauchers with thalassemia.
Oh.
The unusual case we just presented and
Yeah.
took her help, of course.
Okay.
Dr. Mandal, you would like to ask some questions?
Okay, ma'am. Yes, ma'am. Sure.
I think I'm louder enough.
Thank you, Dr. Madhulika, for excellent presentations. May I ask a few questions?
Sure.
Because we have to deal with this because the cases come late to us, say 4 or 5 years with neurological manifestations also. So if we start, because we can't deny the treatment at that age, if we start with enzyme replacement, how much it is reversible, and what age we can say that no meaningful recovery is possible, and we really can't.
Okay. So, sir, for neuronopathic Gaucher disease, type 2 is out. Type 2 enzyme replacement is not recommended. For type 3, though it is recommended, but the neurological manifestations would not reverse. They may progress also. So type 3A, as I told you, is the most severe form of neuronopathic Gaucher. So these children have significant neuroregression, myoclonic seizures, cerebellar involvement. And in these situations, if we start enzyme replacement therapy, it will only be the visceral and the, say, hematological parameters, and to some extent, bone parameters are going to improve. Neurological manifestations would not improve. Whereas the type 3B, which seems to be more common in our country, these children primarily have the kind of eye signs which I tried like to show. And these children usually, the eye signs would not, again, they will not revert. But then organomegaly, thrombocytopenia, anemia would revert. So what we do, because the severe neuropathic Gaucher disease, these children are quite compromised. So we try to explain to the parents that giving ERT is really not going to help, because that's the primary problem in those children. But in type 3B, we can use, and same is true for type 3B, but it is recommended for all type 3 drugs. But we have to sort of, when we are so whenever we are giving a recommendation, see, we get many referrals from ESI also, we always give a guarded recommendation. If it's a type 3, we would always write that only visceral and hematological manifestations are going to improve. The neurological manifestations would not improve or worsen. So that's the situation usually. Yeah.
Cases, the bone marrow or stem cell transfer.
Okay. Yeah, sir, actually, this is a very important question. Because of lack of time, I didn't cover that. So bone marrow transplantation or hematopoietic stem cell transplantation is a very important entity which can be used for treatment. And I think it should be explored more in our country, because it is available in our country. It is a one-time cost, though the morbidity associated is there, match donor and things like that. But once if it is successful, it is like a cure. So earlier for Gaucher also HSCT was being done, but after the availability of ERT, which is very effective, at least in type 1, it is not being used. But I think it's a very good idea that we should have centers. We should take patients for not only Gaucher disease, but for particularly for other disorders also, early life, if we can do HSCT, and sort of there should be some help in these patients, because the enzyme replacement therapy is exorbitantly expensive and it is lifelong. So for our country, maybe exploring HSCT would be a good idea. And I mean, for some of the disorders like MPS 1 and all, it's being done, and for many other disorders. But we need more clinicians like Dr. Tathagat to take up patients for HSCT for lysosomal storage disorders also. You told me that you have a bone marrow
we have
unit
just started
here.
the transplant, of course. We have got miles to go.
Yeah.
We've started, we've got an allogenic transplant in place, but the IBMTR data regarding Gaucher's and other lysosomal storage disorders is not what we deserve. I mean, the earlier they come to us, the better.
Definitely.
And I think this particular aspect, which Dr. Mandal and you have explored, I think is worth researching and getting the transplant done and preventing the lifelong therapy.
Sure.
Yeah, that's true.
The incidence you told,
Yes,
incidence you told is 1 in 4,000. So all these are candidates for treatment.
It's more exciting to know, because once a long time back, we were putting a lot of hope that once the genome project will be complete, at least we will be able to manipulate the single gene defect like Duchenne's and others, and probably it will be curable. So how far we have traveled in, say, genetic manipulations?
Sir, actually, it has been really good in the last few years. I never expected in my lifetime that we will have as many gene therapies available. So, it is available for spinal muscular atrophy type 1, very effective. And then we have antisense oligonucleotide therapy for SMA, for DMD. DMD long-term outcomes are not really very good, but for many other disorders. So I think it is going in a very good way, and we hope for a very bright future.
Thank you, ma'am. Thank you very much.
So those needs to be answered. You can.
One question has come from Dr. Kedar Khanke, and he has asked, is there a screening test for Gaucher's disease?
Okay, so as I said, usually when a patient who's suspected to have Gaucher disease, we would usually do an enzyme assay along with a biomarker. So biomarker is chitotriosidase or lyso-Gb1. So you can say that these are screening tests, but then the cost of enzyme assay and the biomarkers is almost the same, right? And newborn screening is being offered in the Western world for Gaucher disease because it is treatable. And there again, they are doing enzyme assay on the dried blood spot. So if you want to screen, it is primarily biomarkers which can be used. Thank you.
The incidence is 1 in 4,000.
For a wonderful presentation, and we conclude the session.
I request Dr. Madhulika to please be on the stage for the felicitation. I request the chairpersons to please felicitate Dr. Madhulika. I request the chairpersons to be please on the stage for the felicitation. I invite Dr. Lalit Gupta to felicitate Dr. Parveen Guliani, ma'am. I invite Dr. H.N. Malik to felicitate Dr. Mandal. Dr. A.K. Jaryal to felicitate Dr. Tathagat Chatterjee. Once again, we thank all the felicitators, the chairpersons, and the speakers. For the same session, the next speaker will be presenting the online presentation. The speaker will be Dr. Sanjeeva K. from Bengaluru.
Good morning, everybody. I would like to thank the organizers for giving me this opportunity to share some of my experience with respect to treatment of rare diseases. And I also thank Madam for the wonderful session before me. And in fact, the last answer, last comment she made would lead to this session as an introductory remark that various genetic manipulations now available for the treatment of some of the rare diseases. So the greetings from Indira Gandhi Institute of Child Health, Bangalore. So I'm going to discuss in brief the current status of treatment of rare diseases available to us. So as we all know, rare diseases are otherwise called as orphan diseases. A majority of these are genetic in origin, genetic in etiology. And it is estimated worldwide that around 300 to 350 million people are living with one of the rare diseases. And possibly in India, we don't have accurate data, but it's estimated that around 60 to 70 million are affected with rare disease. And though there are 7,000 rare diseases known to us, around 390 of these are most prevalent rare diseases. That is nearly more than 98% of the population are affected one of these 390 diseases. Now, there are a lot of confusion when it comes to definition of rare diseases across the world. There is no consensus among the different nations on the definition of rare diseases. For example, in US, they say any disease or a condition that affects fewer than 2 lakh people in US are about 1 in 1,500 people. But in India, the work in progress under the chairmanship of Madam Madhulika, Madam, they are working towards developing a working definition for the rare disease, so that we can assess our situation and we can come out with our own policy. Now, UN NGO Policy Committee says that a rare disease affects every aspect of human life. It can be health, definitely the health of the individual affected, as well as the family with a child or a person with a rare disease, the education, the work, and most important, economy. Economy of the family, microeconomy, as well as macroeconomy of the nation. In fact, recently, when we estimated the projected budget to at least cover some of the rare diseases under this national rare disease policy, for a state like Karnataka alone, it came out around 450 crores per annum. And this is just a tip of an iceberg. And you imagine at a pan-India level, so it will hit adversely on the economy of a country when we have to address this rare diseases. Similarly, it has got an effect on the society as well as science. There are a lot of challenges for academicians and basic scientists, and challenges to develop therapies for these diseases, which is affordable and accessible to the patients. Now, basically, I'm a pediatrician, and most of these diseases affect the children. So the most frequent genetic disorders which are seen by the pediatric consultants are, these are the things which the list starts from Down syndrome and beta thalassemia, DMD, and it goes on till the lysosomal storage disorder. And most of us, a pediatric consultant or a pediatricians or even a postgraduate in the pediatric would have seen these cases in their regular practice. So why we need to look at rare diseases, and especially now? Because rare diseases are responsible to 1/3 of the infantile death. So now the IMR is coming down. And now it is around 2021 in some of the states, even it's going down further. So the focus now, we have almost this reduction in IMR is basically due to the effective implementation of vaccination and infection control strategies. Now, with to bring it further down, we need to focus on these rare genetic disorders, because nearly in a state like Karnataka, 3,000 children die every month before their first birthday, and 75% of these deaths occur in the first 4 weeks of life, and majority of them are due to inborn error of metabolism or serious congenital anomalies. So when we talk about management of rare diseases, we can definitely divide into 3 groups. One is having a curative therapy, one-time treatment, curative treatment. For example, if there is a cardiac defect, you just correct the cardiac defect. Or as Madam has already discussed, this lifelong treatment like enzyme replacement therapy. Or in a large chunk of disorders which are not amenable to a specific treatment, in such cases, only supportive treatment is required. So for all these 3 types, it's not just curative treatment or lifelong therapy. The supportive therapy is also critical. We need to address that. So there is a major role for us to bring all these multidisciplinary supportive therapy under one roof, so that we can give a comprehensive care for these patients with rare diseases. Now, I showed a list of conditions which are commonly seen in our clinical setup. The topmost is beta thalassemia. It is estimated that about 10,000 children are born in India each year with thalassemia, and there are over 20 million carriers are estimated in India. We all know the clinical features of beta thalassemia. It's a blood transfusion dependent condition. So this child needs blood transfusion every month. As a result of that, there will be iron deposition, so iron overload, hepatosplenomegaly, cardiac involvement. So it can affect every part of the body. Now, how do you manage conventionally? So conventional treatment is lifelong blood transfusion with iron chelation therapy, and the 30-year survival is around 85 in a well-chelated child. But what our experience is, most of these children, they don't survive to 3rd decade, And I mean, the hematopoietic stem cell transplantation has come out in a big way as a one-time cure for these patients. So a data which is published data in 2005 from 6 transplantation centers in India at that time, a total of 1,540 transplants were reported. And in that, the transfusion-free overall survival rate in a HLA matched sibling stem cell transplantation patient is 85 to 90%. So this is a fantastic results. In fact, in our center, we have done more than 100 transplantation, and transfusion-free survival is more than 90% there. Now, the biggest challenge for this transplantation is availability of HLA matched donor. So to overcome that donor, nowadays, a lot of people are going for haplo-identical transplant, that is parents who has got 50% match or more than 50% match. So they are transplanting that, and that protocol is evolved over a period of time, and the results are as good as in a HLA matched sibling. It's not, I mean, it may not be equal to that, but nearly equal to the HLA matched stem cell transplantation. So now there are a lot of conditions which are amenable to hematopoietic stem cell transplantation. I'm giving just beta thalassemia as one index case, whereas there are a lot of conditions like your osteopetrosis. I mean, madam has already discussed on MPS. So there are a lot of conditions. The list is growing every day with new knowledge coming in. So we need to think hematopoietic stem cell transplantation as one of the component or one of the curative option for many rare diseases, rare genetic disorders. Now, I think most of us would have seen these type of children born Harlequin ichthyosis. And many a times when I was postgraduate or during undergraduate, whenever we see these type of children, most of the time parents as well as the healthcare professionals used to abandon these children, and most of them used to die in the neonatal period. But this is again a treatable condition. It's a severe form of ichthyosis, ichthyosiform erythroderma. They will have stiff and thick skin. They will have ectropion of the eyes and O-shaped mouth. So they will have temperature regulation abnormality. It lead to skin infection, restrictive dermopathy. Many a times these children die because of electrolyte imbalance in the newborn period. It's an autosomal recessive disorder with 25% recurrence in the next pregnancy. The treatment is you can give vitamin A derivative, and those who survive the infancy, they usually do get better. Here we have a child who was born like this in 2007. This is after 3 years of age with vitamin A derivative therapy. This child is, apart from skin, she otherwise doing fine. And many genes can cause this type of disorder. So it is extremely important to do a genetic diagnosis so that you can prevent the recurrence in the subsequent pregnancy. And the next most common condition, which madam has already mentioned in her comment in the previous session, Duchenne muscular dystrophy. We all know this is an X-linked recessive disorder. Here in an affected child, affected male, there is a progressive proximal muscle weakness leading to increased duration from sitting position to getting up from the sitting position. That's called as Gover's sign. They will also have hypertrophy of the calf muscles. It's called pseudo hypertrophy. It's not exactly the hypertrophy. It is basically fat deposition in the place of damaged muscle. So it's a pseudo hypertrophy of the calf muscle. And the test of choice to diagnose this condition, I mean, molecular test of choice is something called as MLPA. So here the dystrophin gene, which is located in the chromosome X, gene is amplified and it is tested. So this is the therapy for this is a perfect example for personalized medicine, which is now many people talk about. See, when we look at the molecular abnormality underlying Duchenne muscular dystrophy, 60 to 80% of these children will have something called as deletion. A part of the gene is missing, whereas 7 to 11% of them will have duplication, and 10 to 15% will have nonsense mutation, that is a point mutation or a point mutation. So these deletion, especially particular deletion, if there is a deletion involving exon 45, 51, and 53, they are amenable to manipulation through something called as AON, that is antisense oligonucleotide mediated exon skipping. So it skips that exon and reads through the frame. So you will have a truncated protein, but a functional protein. So what's happening is here you are converting a life-threatening dystonia muscular dystrophy into a modified, milder form of Becker-like phenotype. So this is available now, as Madam said, and it's also known that the long-term effectiveness is still don't know, but in the short term, it is showing some promising results. And in fact, in the Western countries, it is approved for the clinical use. So here, the still further data is available, is awaited to recommend that to our patients. Similarly, for a point mutation, a new drug is available called atalurin, which will again read through that point mutation, and it will lead to a functional protein, and it will modify the disease progression. So there are some Indian companies which are manufacturing low-cost A1s now. The trial is going to start in few of our centers in India. If that is available, then probably we'll have a cost-effective treatment, locally made. Perfect example for the local availability of these rare disease treatment. Spinal muscular atrophy. It's again a life-threatening condition affecting 1 to 6 per 10,000 births. So infantile form, majority of them, they die of respiratory failure within the first year of life. So it is due to mutation in the SMN1 gene. Usually the exon 7 and 8 are deleted. There are three therapeutic options available. One is nusinersen, risdiplam, and gene therapy. Nusinersen is an intrathecal medication which is used as an exon skipping agent. Similarly, what I described in the previous context. Risdiplam is an oral medication for exon skipping. It is given lifelong. And gene therapy is a John Gelsma. I mean, you would have seen everywhere. It's a it is the most costliest therapy available, 16 crore therapy. So it is a one-time therapy. If you select the patient properly, the outcomes are very good. So these three therapies are available for these patients. Risdiplam is registered and is available in India, whereas these nusinersen and gene therapy can be brought into the country on a named basis, on a patient-to-patient, case-to-case basis. Another group of patients in a rare disease is skeletal dysplasia. These are inherited disorder of skeletal system. Nearly 461 disorders categorized into 42 groups are known, and 92% of these disorders are mapped to a particular genes. So the overall incidence is 1 in 5,000, and it can be dysplasia where affecting the bone and cartilage tissue growth, or dysostosis where the abnormal development of one or more bones affecting the ossification. So we all know the achondroplasia is the most common non-lethal skeletal dysplasia. So these children are cognitively fine, except for the growth, restricted growth. They are otherwise they are fine. So they have the rhizomelic shortening of the long bones, and this trident sign, which is very classical sign of achondroplasia. We can make a diagnosis of achondroplasia even in utero by looking at this trident sign. So the cause for this achondroplasia is in 98% of the time it is due to a specific mutation, that is 1138G2A in FGFR3 gene. So what happens when there is a mutation in FGFR3? It leads to overactivity of the downstream pathway, and end of the day it will suppress the chondrophyte proliferation and differentiation. And naturally there is something called as C-type natriuretic polypeptide, that is CNP, which actually inhibits this overactivity. So the problem with the CNP was the half-life of CNP was very short. It used to be in minutes. So it was very difficult to develop, administer to a patient with FGFR3 mutation, resulting in overactivity because of the short half-life. So an analog of this, that is BMN 111, was developed, and it was used in a trial to look at the effectiveness of this CNP analog on the growth of the patients. So there was a promising resulted in approval of this as a first drug to improve the growth in children with achondroplasia. The FDA has approved 6 months back. This is called osoritide injection to improve the growth of children with achondroplasia who are 5 years and above, and whose growth plates are still not fused. So this is again available, not in India. Definitely it will come. So we can offer when it is available in India. Another group of disorders are inherited metabolic disorder. So madam has discussed in detail about lysosomal storage disorder and various disorders, various enzyme replacement therapy available. I'm not going to go in detail. There is something called as every one of us use this ambroxol as an expectorant in our daily practice. So ambroxol as a mucolytic agent. No, in many of these lysosomal storage disorder, because of mutation, what happens is these proteins are misfolded. If you can remember some of the biochemistry, when in the protein, the folding happens, primary folding, secondary and tertiary folding. So this folding is to give the stability to these patients, to these proteins. So a misfolded protein is very unstable, which disintegrate or degenerate very fast. The half-life of this misfolded protein is very short. So that is the reason why these proteins, even though they are truncated, they are abnormal, they are not available for the action in these diseases. So what these chaperones does is, chaperones are the small molecules. They will rescue this misfolded protein. They will increase the half-life. So the availability of these proteins are increased. So ambroxol is one such agent which is been now thought of to be used in chaperone therapy, as a chaperone therapy in Gaucher disease. So it's a repurposed molecule. And we all know phenylketonuria. So it's a condition where inborn error of metabolism in the phenylalanine pathway, leading to mental retardation, behavioral and social problems, seizures, hyperactivity, skin rashes and musty odor in the skin, in the child's breath, skin and urine, microcephaly, and fair skin and blue sclera. So the therapy is restriction of phenylalanine in the diet. So this medical diet was available in the Western countries from last 30 to 40 years. And it's a very effective therapy. Unfortunately, this therapy was not available in India, and we used to import these drugs, these foods from abroad, which used to cost around nearly 60 to 70,000 per patient per month. Now, with when we partnered with a local baby food manufacturing company in Bangalore, and we started producing these drugs, these medical foods in India, the cost has reduced to nearly 1,000 rupees per month now. So currently 14 different metabolic diets are available for different disorders, and the effectiveness is as good as any other internationally available drugs. So, and there is also low protein flour to produce, prepare some of the everyday day-to-day diet for these patients is also available locally now. This is available, this is manufactured in Bangalore, but is available everywhere in India now. Online also it is available. So there is another drug called Kuvan, that is tetrahydrobiopterin, Kuvan sapropterin dihydrochloride. So this is used as an adjunct therapy in a milder mutation with a residual pH activity. So it will augment the residual pH activity, always used in conjunction with the phenylalanine residue reduced diet. So newer studies indicate safety for use in a pregnancy. So various therapies available like tyrosinemia type 1, alkaptonuria, Wilson disease. We all know, we would have already treated many of the patients, PKU, homocystinuria, cystic fibrosis, retinitis pigmentosa, and gene therapy. Another condition I would like to bring it to your notice is Prader-Willi syndrome. It's the most common pediatric genetic syndrome with obesity. So, almost 20 years back, FDA has approved recombinant human growth hormone therapy for the treatment of Prader-Willi syndrome. Because of cost, it is not used extensively, but some of our experiences, when it is used very early, the results are really good. It decreases the weight, increases the height, improves the behavior and cognition, improved bone mineral density and lipid profiles, decreases visceral adipose tissue. Sleep study is required before you start or after starting the human growth hormone therapy, because obstructive sleep apnea can be worsened due to this therapy. So you need to consider that. But in adult, it can be considered, but cost is an issue here. So Marfan syndrome, we all know it's a triad of arachnodactyly, subluxation of lens, and aortic root dilatation. Here, the life-threatening component of this condition is aortic root dilatation. Again, this aortic root dilatation is due to the mutation in FBN1 gene, which lead to an abnormal or deficient fibrillin protein, which is a structural protein in the extracellular matrix. And with this mutation, there is an increased activity of transforming growth factor B, that is TGF beta, and this leads to progressive dilatation of the aortic root and lead to dissection and death. So we would have used losartan in our day-to-day therapy for so many conditions. This losartan is an angiotensin II receptor blocker, which actually blocks the enhanced transforming growth factor beta activity. So it suppresses the TGF beta activity. Thereby, it will prevent the aortic root dilatation. So studies have shown the effectiveness of this therapy. So with just losartan, starting at an appropriate stage before the dilatation sets in, you can prevent the life-threatening event in these patients. So neurofibromatosis, apart from the other manifestations, the most important manifestation is flexiform neurofibromas. Many of them are inoperable and they can be symptomatic. So for this, protein kinase inhibitor oral medications like selumetinib can be used to reduce their tumor size and it becomes operable. So trehalose is another commonly used drug which we use as a artificial sweetening agent. So it's a naturally occurring seizure, a non-reducing sugar, non-reducing disaccharide with 2 glucose molecule, and it acts as an autophagy inducer. Now there is a lot of focus on autophagy. In fact, the recent couple of years back, a Nobel Prize was given to the proponent of autophagy. So degradation of macromolecules, which depends on the function of the lysosomal apparatus. The characteristic feature of this process is engulfment of the organelle structures or a molecule to be degraded by an intracellular membrane and formation of autophagosome and its fusion with the lysosome. So this is what happens in autophagy. And most of these lysosomal storage disorder, the autophagy is dysfunctional, leading to the accumulation of these macromolecules and the clinical manifestation. So this trehalose induces the autophagy. So it has got its role has been explored in many neurodegenerative disorders like Niemann-Pick, MPS IIIB, which is not amenable to any of the conventional therapy, Huntington, Parkinsonism. So the disease, the list is going on. The initial trials are showing some promise. So lot of road to be traveled in this path before it comes to the therapy. So some of these molecules are common molecules which are repurposed, like pamindronate or imitinab or metformin. They are repurposed for many of these conditions. So I'll given the list of conditions previously. So majority of these are amenable to some sort of therapy, which I discussed. So another important thing is awareness. due to lack of awareness, I'm going to discuss that. Because of lack of awareness, these children are diagnosed late. So when they come at that time, the therapy may not be very effective. So National Rare Disease Policy, Madam has touched upon that. So he is now approved by the government of India. So out of these, there are 8 centers of excellence has been identified. And in this National Rare Disease Policy, the treatment of the therapy, the treatment of rare diseases are categorized into 3 groups: Group 1, Group 2, and Group 3. Group 1 is one-time curative therapy available through your bone marrow transplantation or organ transplantation. Group 3 is low-cost continuous therapy like metabolic diet, growth hormones, and other things. Group 3 is high-cost lifelong therapy like enzyme replacement therapy, and various funding mechanism has been formulated in this policy. So our experience is, we have around 219 children with various rare diseases are under our treatment. Majority of them belongs to Group 2A, and some Group 3A, and a few of them are Group 1A. So this is a family with MPS type 4 who has undergone bone marrow transplantation. This child is an index child, and this child was diagnosed in utero, and this is an unaffected elder sibling who is a donor to this younger child. Because when we saw this index child, he was already, the age was not conducive for bone marrow transplantation. So now this child is post BMT 2 years. They come from a very poor family background. You can see the background, and they are migrant laborers, construction laborers. So we could able to achieve good result with the bone marrow transplantation in these patients. So the hope for the future, more innovative therapies are in clinical trial available. Some are common medication repurposed for use in rare diseases. The challenges is to make these therapies affordable and accessible to all who require it. So again, challenges are heterogeneous nature of the rare diseases. It's not a single disease. When we say rare disease, there are many diseases, and its treatment are also, as I said, it's a personalized medicine, perfect example for a personalized medicine. So these are inherent and a major barrier. We don't have a local prevalence data, and delayed diagnosis will lead to the missed opportunity, because when the therapy is initiated at an appropriate time, the outcomes are fantastic. The specific and optimal therapy is not available for majority of the rare diseases currently. And most important challenge is family commitment when the therapy is lifelong. If that commitment is not there, then the outcomes are poor, and the cost intensive management is also another challenge. So journey so far. So earlier we had only clinical diagnosis. So we needed excellent clinician like Madhulika ma'am to do a clinical diagnosis at that time. Now with the newer technology available, so molecular diagnosis is now available to almost all rare diseases now. And this has also led to the better understanding of the disease pathway and what is really happening, what is leading to these problems. And this has led to identification of therapeutic targets and development of therapy. With this, I would like to conclude my talk. I thank you for the attention. I also acknowledge Dr. Meenakshi Bhatt to sharing her slide and as well as her knowledge. She was supposed to be here in this platform. She is not there. She has gone out of country. So instead of her, I'm pitching in her place. Thank you for attention. I'd be happy to take any questions from the audience.
Any questions from the audience?
Thank you for a nice presentation. My concern with the rare diseases is this, that most of the clinicians, doctors, treating surgeons or doctors, they are not aware of rare disease centers. If you see on a WhatsApp, many people, they keep on collecting the money for such patients. Plus, when we talk to our friends for the centers like this, 8 centers, number one, the centers are like, there should be more centers and it should be more publicitized so that doctors comes to know about it and they refer the patient to the right place and the treatment is given timely to these patients. So this is my concern. Thank you.
I think, sir, you have actually hit the nail on the head, sir. I mean, what your comment is absolutely valid. I mean, in the national rare disease policy also, they are in the process of expanding these facilities where the treatment and the even the diagnosis, prevention, everything is available. So they are now planning to extend this whole facilities. It is still in a very early stage, though this policy was formulated 1 year back. There are a lot of background work is happening. So developing the guidelines. It's not simple. Like there are many diseases and you need guidelines for each and every group of diseases also. So developing technical guidelines, operational guidelines, identifying the centers where these therapies are available. Definitely, I mean, awareness is one thing which is again important. So all these are work in progress. Maybe down the line in few months or in a year or so, we would like to see that happening in a major way. I mean, that's a really point of concern for all of us who are working in this field, sir.
This is Dr. Chatterjee. Nice presentation. You have discussed about 8 centers as centers of excellence for therapy. What about the centers for excellence for molecular diagnosis of disorders? Are the same centers specializing in molecular diagnosis, or you have separate centers which are yet to be unfolded?
Sir, actually, when you look at these center of excellence, 8 centers, they are actually identified with all these strengths together. For example, molecular diagnosis, preventive aspect, capacity to provide therapy, not only a specific therapy, even the supportive therapy. So where these things are not available under one roof, they have actually clubbed the couple of centers together as a center of excellence. For example, in Hyderabad, CDFT as well as Nizam Hyderabad have been clubbed as a center of excellence. Even in Bangalore, Center for Human Genetics and Indira Gandhi has been clubbed as a center of excellence, where if it is available under one roof like AIMS or SGPGI, I mean, it's given as one center. So the idea is to provide a comprehensive therapy under one roof. But this list is not the final one. This list is going to be expanded, and there will be definitely different tiers of system will be established. For example, at the apex there will be the center of excellence, and there will be regional centers, and there will be peripheral treatment centers. Thoughts are going on to develop these things, where once the diagnosis is done, only the management can be done in a peripheral treatment centers also. We don't want the patient to travel for a longer distance to avail therapy, because many of these therapies are recurrent. You need a patient to come to the healthcare facility very often, many times weekly once. So it may not be possible for the patient to travel every time. The travel cost, a lot of other problems also there. So end of the day, to decentralize this, the plan is there, but it will take some time for this to happen, sir.
Sir, thanks a lot for nice presentation. Myself, Dr. Ratan. I wish to know only one question. What is the current status of premarital genetic counseling in India?
Sir, actually, prenatal genetic counseling is, currently it is picking up. When we say in last 10 years, there is a lot of progress in this prenatal genetic diagnosis, prenatal testing also. Various centers have come up. Initially, we had around only in major cities we used to have 1 or 2 centers, but now there are more than 50 to 60 centers throughout the country available. Definitely, it is available in the major cities even now, and with the initial challenge was the availability of molecular diagnosis, and majority of the prenatal diagnosis is based on the molecular diagnosis. Only few where there are markers we used to do the other modalities, but majority of the time it used to be on the molecular diagnosis. So the most important breakthrough in that was the new generation's sequencing, NGS. So now we have molecular diagnosis platform available, so we can make a molecular diagnosis in majority of these cases. So potentially all of these are amenable to prenatal diagnosis potentially. Now the question is the facility. So now the facilities are there in the major cities. So what this national rare disease policy is aiming at is, under national rare disease policy, all medical centers are supposed to develop a department of clinical genetics, and as a part of that, prenatal diagnosis is also a feature of that particular department. So maybe in another few years we are going to have this in all medical colleges, prenatal diagnosis.
There is one more question from the audience. Dr. Kedar Khanke, he has a question that under the national rare disease policy, the funds are made available to the patient, or whether the patient has to go to one of the designated treatment centers which would take care of the management of the patient.
So currently, the funds are these diseases are categorized into 3 groups. So the group 1 is those conditions which are amenable to one-time treatment, like bone marrow transplantation. For example, a very young child with a MPS type 1 or something like that. So here, this is covered under that Rashtriya Arogya Nidhi. So the places where Rashtriya Arogya Nidhi is available, they can undergo bone marrow transplantation, and the ceiling limit is 20 lakhs there. In the group 2, these are the conditions where the therapy is recurrent and lifelong, but the cost of therapy is not very high. For example, metabolic diet. Here, the policy mandates the state government to take the responsibility of this. Still, many state government are in conversation with these conditions. For example, in Karnataka, the state government has provided some funds for primary immunodeficiency, which is group 2. So that continuous therapy, chronic maintenance therapy with immunoglobulin can be provided for these patients. Whereas group 3 is the major headache. So here the policy says we are going to mobilize CSR funds for this. So these funds will be on the case-to-case basis. It will be provided to the centers. It will not be provided to the patients. It will be provided to the centers, and patient has to avail therapy through those centers, because there are a lot of other issues also. It's not just giving one enzyme. These children need to be monitored. Their therapy should be modified according to their growth and other parameters, and even the procurement, everything. There are a lot of other issues also. So currently, the policy says the mandates the funds will be released to the centers on the case-to-case basis, and the patients will avail therapy in these centers. These centers, the list of these centers are in an expansion mode. And end of the day, this therapy should be reachable to each and every patient.
Thank you, Dr. Sanjeev, for excellent presentations. You have given us a very good insight into the future of the genetic manipulations and therapy, which is available in our places. Thank you very much. You had a very nice presentation. Thank you. Thank you again.
Thank you, sir. Thank you.
I thank all the chairpersons and the felicitators for the session. We'll make sure that the felicitation memento for Dr. Sanjeeva will reach them via online portal. Without any further ado, I would like to move toward the next session of the event, which is titled as Clinical Research in India, an Overview. The chairpersons for the session will be Dr. S.K. Vajpayee, Dr. Lalit Gupta, so in this session, we have two speakers with different topics. Firstly, we'll have Dr. H.S. Rehan, Director, Professor and Head Pharmacology from Lady Hardinge Medical College. His title will be Familial Hypercholesterolemia. We'll have first his sessions. I request the chairpersons, Dr. S.K. Vajpayee, Dr. Lalit Gupta, and Dr. Monica ma'am, to please chair the session. Dr. S.K. Vajpayee is Senior Professor of Pharmacology. He is the former Dean at Government Medical College, Surat, also the founder president of Indian Society of Hypertension. Dr. Lalit Gupta is Director, Professor, Department of Physiology at Lady Hardinge Medical College, New Delhi. Department of Pharmacology at Lady Hardinge Medical College, New Delhi. He has worked as member of Institutional Human Ethics Committee and Institutional Animal Ethics Committee at Lady Hardinge Medical College. Also a member of various subject expert committees of Central Drug Standard Control Organization. Appointed as member of Anti-Doping Disciplinary Panel for National Anti-Doping Agency of India for 4 years. Dr. Monica Agarwal is Professor and Head of Department of Pharmacology at ESIC Medical College, has worked in prominent institutions like Maulana Azad Medical College and PGI Chandigarh. She's also the National Coordinator for Pharmacovigilance Program of India, played a prominent role as principal investigator in research like prescription audit of drugs and psychiatry OPD of a North Indian tertiary care teaching hospital, has been distinguished as a member of National Academy of Medical Sciences and also a life member, Indian Pharmacological Society, Indian Society for Rational Pharmacotherapeutics. Till now, she has published 25 plus original research papers in various prestigious journals. I would now request the chairpersons to please chair the session.
Good afternoon, ladies and gentlemen. It's my pleasure to introduce our speaker, learned speaker, Dr. H.S. Rehan, Harmeet Singh Rehan. He is Director, Professor and Head of the Department at Lady Hardinge Medical College, New Delhi. He has been awarded with Commonwealth Fellowship in UK. He is also a visiting professor at University of Durham, UK. He is subject expert to several national and international professional bodies like CDSCO, ICMR, Central Insecticide Board, WHO. He is a prominent member of several National Health Program of India. He has been pioneer in generating organs from autogenous stem cells. He has published 110 original research papers in national and international journals of repute. He has been a coordinator pharmacovigilance and material-vigilance program of India. He has developed consensus guidelines for the management of dyslipidemia in Indians, and he has been awarded several prizes for research and publication. And more than that, I know Dr. Rehan for many, many years. We have been meeting again and again, and he has many qualities which make him so popular. And in any meeting, wherever he is there, he makes the things quite lively. And I hope today also we will enjoy his discourse.
Sure.
Dr. Rehan.
Thank you, Dr. Vajpayee. You're a wonderful senior, wonderful person, and always keep on encouraging your younger brothers and the younger colleagues. Thank you. Respected chairpersons, Dr. Monica, Dr. Lalit, along with Dr. Vajpayee. And the most valuable delegates present here. Very good afternoon to all of you, and other participants, those who are online. Warm greetings to them also. my BMI is 23. Why I'm saying? Because I always say the day when I'll lose my ideal BMI, I'll stop working for Lipid Association of India, or I'll stop presenting my talks as in a dyslipidemic meets. No doubt about it. My ideal Dr. Lalit sitting here is the most fit person now. He's in our department, and rather I'll say that he's the fittest of our institution. So this is very important that we take care of ourselves. Normally we doctors, we don't take care of ourselves, and we always believe that सब ठीक है, सब चंगा है, कोई बात नहीं, हो जाएगा, आज नहीं होगा, कल हो जाएगा. But there is a reason that why we need to control our lipids. As Indians, we are very prone to get CAD, coronary arterial disease. Prone means 10 years ahead of the European population, we get the heart attack. And as a serious concern. Our diet habits are like this. We take more of the carbohydrate. Protein is less. Genetically, we are different. Genetically, if we see that we Indians have not very high LDL, but very low HDL. TJ is high, LDL is high, and HDL is low. So from all the sides, if we see, we are at risk. So today I've been asked, or I'll speak on a familial hypercholesteremia. This is another concern where we becomes more prone, such patients, those who have familial hypercholesteremia, they become more prone to the CAD as compared to the other Indians. And we have developed the guidelines for that also. As a familial hypercholesteremia, it's a genetic in nature. It's a monogenic, means one gene is involved, one gene is defective. And we did this study in our department, and we found that many people, dyslipidemic, have a monogenic defect in them. So taking a lead from them, a result of the monogenic disorder, LDL levels are high. In layman language, we say that LDL is a bad cholesterol. So LDL is high. This makes us prone to cardiovascular event if left untreated. And it can happen prematurely also, especially in a familial hypercholesteremia. At very early age, ACDB can occur, atherosclerotic cardiovascular disease can occur. And this can lead to an early death. Early CAVD event, major atherosclerotic cardiac event can occur. Normally, how we make the diagnosis, we don't do genetic study much in our country, as in the earliest presentation we were also listening. If the mean age for the diagnosis is 50, by which time 1/3 of the patient has already experienced ASCVD event. When we listen today, the young person, 21-year-old, developed the cardiac event or heart attack or CAD. So this is very serious concern. By the age of 50, 1/3 of the patient already have ASCVD event. And this is a foundation cascade familial hypercholesteremia registry according to that. Clinical diagnosis is made on the physical findings, depend upon the personal history and the family history, how many has a similar disease in the family, dyslipidemia in the family, or if the person is diagnosed to have. And once we did a study in school children, and we found 23% children were dyslipidemic, school children up to the class of 10th. And then the genetic study was done. 3 boys were found to be familial. We had a problem. Their parents were not ready for the further diagnosis, further investigation, family tree follow-up. That was a problem. And this is awareness which is absolutely lacking. And we had to see, we are worried. We cannot force anybody to take the treatment. Ethical issue comes in between. But there was a problem. Hypercholesteremia at the early onset ASCVD and circulating LDL cholesterol high. This picture shows that how in a liver, if you see, we know that from acetyl coenzyme A, cholesterol is formed from the cholesterol with the help of association of ApoB100. ApoB100 is associated with LDL, PG, and VLDL. So this association with the lipo LPL enzyme converts into LDL. LDL acts on the LDL receptor in the liver on a hepatocytes, and hepatocytes takes that. So it binds to the LDL receptor along with the LDL enters into the cell in the lysosome, and then what happens? Cholesterol LDL is metabolized, and this receptor recirculate and come back to the surface. So LDL receptor is very important, and we see that autonomic autosomal recessive hypercholesteremia, as we see that the internalization of the receptors we see, and PCSK9 is a target. We see here in a 69.7% of the patient, LDL receptor is defective, and this is the most common cause. Our study at Lady Harding also shows the similar effect, that LDL receptor was defective in most, followed by PCSK9, 5.7. PCSK9, if we see, maybe in a subsequent picture, we will see that PCSK9 binds with LDL. Then this complex bind to LDL receptor. This complex internalized in the cell in hepatocytes. And then there is a metabolism of LDL, PCSK9, and the receptor. Everything is destroyed inside. So now LDL is not recirculating, not coming to the surface again to catch another LDL molecule and to bring it inside for the destruction. So this results in increase in LDL level. So this way we see that LDL receptor mutation and a gain of function. Gain of function means if PCSK9 function is enhanced, gain. So more and more LDL receptor will destroy. And more LDL will be higher in the blood. So this is very important target that if we inhibit the PCSK9, destruction of LDL receptor will not take place and the recirculation will be possible. So this is one of the targets. If we say that HMG coenzyme A, we all know it's a target for inhibition of the synthesis of cholesterol. We all know that HMG coenzyme A from acetyl coenzyme A. Acetyl coenzyme A comes from the TCA cycle. We can inhibit there. From the TCA cycle, acetyl coenzyme, if it is not formed, then cholesterol will not form. If we take care of inhibit the ApoB, then VLDL and will not come. If we inhibit the lipoprotease lipase A, then LDL will not form. So these are the potential target which we can explore. Right now, presently the therapies which are available for the treatment of hypercholesteremia or dyslipidemia are statins, ezetimibe, and bile sequestrant, and many other. So diagnostic criteria is important. So US MED, PED, that is a make early diagnosis to prevent early death criteria, is followed in US. In UK, Simon Broom system is formed. Lipid Association of India also follows the Simon Broom criteria. Dutch Lipid Clinic Network criteria is the most vast, and it is also where the positive genetic testing is must and accompanied by the additional measure like elevated LDL to fulfill the definite diagnostic criteria. Most detailed assessment for the likelihood of the diagnosis as a heterozygous familial hypercholesteremia. NLA also recommended similar panels. So these are the different bodies or recommendations: Simon Broom, NLA, that's a National Lipid Association, American Heart Association, Lipid Association of India, and MED-PED. And these are the criteria like premature CAVD in the family history. And the tendon xanthomas. Xanthomas we very commonly we see, and we try to around the eyes we see xanthomas, and from there we take a lead that yes, there is a deposition of the cholesterol which needs to be, and it's a reversible if it is treated properly. So family history of a hypercholesterolemia, patient with premature CAD, patient with premature peripheral vascular disease. Is not only that the heart disease, heart blood vessel, coronary blood vessel will be affected. Blood vessel of all the body will be affected. It can affect the coronary carotid artery also, and can lead to so many complications in the peripheral blood vessels also. Sulcus, corneal arcus, elevated LDL, and genetic mutations. So these are the criterias in LAI recommends that there should be a family history. There should be a family history of the tendon xanthoma and the patient with hypercholesteremia, tendon xanthomas, corneal arcus, and elevated, and the genetic mutation. So these are the criteria. Of course, the genetic testing is not very prevalent. Though we started and we are also taking time to give, because for half of the process we do at Lady Harding, half of the process we are dependent on other institutions, and that really takes time because whole of the North India is dependent on IGBI for the investigation. They are doing tremendous work, and we are also we collaborate with them. So management, if we see, management is very important. Early diagnosis and early treatment, early intervention is very important to remove the cumulative burden of elevated LDL cholesterol and prevent or delay the development of ASCVD. So every treatment we see that how many MACE have been reduced, how many attacks have been reduced, cardiovascular events have been reduced, treatment strategy based upon the serum lipid levels. Earlier in a normal, we used to say that 130, many labs still today says that less than 130 is normal. Lipid Association of India and other bodies, now they recommend that 100 is the upper limit. So things are becoming stringent so that we really take care of the treatment as early as possible, as vigorous as possible. Pharmacotherapy of choice, statins and ezetimibe combination is good, and if patient can tolerate statin is good enough. In case of familial hypercholesteremia we see, then low intensity statins will not work. We need to give statins to a high intensity, maybe 20 milligram rosuvastatin or even at times more. But patient should tolerate that. If patient is unable to tolerate the 20 milligram, then we should come to the 10 milligram. If patient is intolerant to even 10, then we should change the statin. That is a protocol we follow for a statin intolerance. Then we should give the atorvastatin equivalent to 40. If they tolerate, because 20 is equivalent to 40 of atorvastatin. If they tolerate as well, good enough, continue. If they don't tolerate, reduce the dose, and there is a problem, then we label the patient as a statin intolerant. So most of the time this happens, but we need to follow the protocol to label a patient statin intolerant, because this is the most successful drug for decreasing the lipids available. It can decrease the LDL level by 45 to 50% of the LDL level can be reduced with this. And when the desired targets are not achieved, ezetimibe is a drug which we prefer to give. If still there is a problem, like in a familial hypercholesteremia, this a combination of the drug may not be sufficient to achieve the targets. Targets means really we need to achieve the targets very low, up to 70 milligram. If it's a heterozygous, the new LAI recommendation says that in a 2020, it was recommended that it should be 50. And if there is a ASCVD, patient has already had the heart attack, then the LAI recommends that we should maintain 30, less than 30. It appears that how a 30 can be maintained. Yes, it can be maintained. Otherwise, cardiac event will occur. So these targets, if we fail to achieve with the medicine, then apheresis is done. It's not very common in India, but we have started with apheresis, though almost dialysis is done and lipids are removed, especially for the patient, those who are resistant to treatment. If the statin is not working, ezetimibe is not working, then you have to remove the LDL from the cholesterol from the blood. So apheresis will come in picture. In UK, it's a very common practice for FH patients and start treatment as soon as possible to prevent the development of cardiac events. And the new strategies we will discuss, we will not discuss statins and other, because that we all know, and the new strategies which we have, and the diagnostic criteria we have discussed, that LDL more than 190 in adults and LDL more than 150 milligram per deciliter in children is a criteria to diagnose along with others. And then we confirm the diagnosis by excluding secondary causes of dyslipidemia, apply clinical diagnostic criteria, genetic testing if available, assess other cardiovascular risk factors, cascade screening of the family by lipid levels. So by the genetic level, whatever is available, we ascertain the diagnosis before we label the patient as a FH patient. Then how we manage? Most of the things we have discussed, that adults without ASCVD, we keep the LDL level less than 70. So 130 is not the normal limit. Normal limit for all of us is 100. And 50% reduction with the drugs, and adults with ASCVD less than 55, and the children less than 10 years, 135. In the children, we don't reduce the cholesterol to that level because they need cholesterol for the growth. And sometimes you can say that why 30, how the patient will work, how the brain will work. When child is born, lipid level of the newborn child is 30 milligram deciliter only. That is a time when the maximum amount of lipids are required for the baby to grow. So this way, if we maintain 30 and the risk factor is there, is absolutely no problem. Dietary and lifestyle support is important. Statin as a first line, add ezetimibe, and then add PCSK9 inhibitor. So dietary, these days we count the how many steps in the, this is a fashion to count. I have done 10,000, I have done 8,000, but most of the steps which we cover like this are within the room. Make it a point to have a minimum of 10,000 in your park. When you're in a jogging park or whatever way, then you see that in how much time you covered those 10,000. So make it a target of 10 kilometers a day, brisk walk. So this will really help you. Otherwise, leisure walk is not going to help much. Low saturated fat, low cholesterol diet, so regular exercise, and the sugar, maida, everything should be stopped. And the samosa is the most favorable thing to develop a dyslipidemia. Maida with the aloo and fried in a oil which has been reheated for the several times, means is a trans fat. Trans fat should be less than 2% of the total fat we take. So if you take one samosa, you have taken trans fat quota for a whole of the month. So this is a thing. I'm not against samosa as such. Is a tasty to eat, but we have to be careful that how we optimize our things. Stop smoking, and because it's another risk factor for the cardiovascular treatment, and find other comorbidities associated. If the diabetes is there and all that should be taken care of, that we have to find, because age itself is a risk factor for dyslipidemia, cardiovascular event. So 55 years itself is for male, and 60 for a female itself is a risk factor for that. So hypertension, diabetes mellitus should be ruled out, should be treated earlier. So we discussed the latest therapies only, and price. Please let me know if I exceed the time. I'll stop whenever you say. So okay. अभी तो माहौल ही गर्म हुआ है. Anyway, so I'll discuss the PCSK9. I'll enumerate few of the drugs. If you see that this aspect, I have already discussed that if we see this LDL in the circulation binds to the LDL receptor, and this gets endocytosed, and this endocytosed this degrades and to amino acid and cholesterol, and LDL receptor recycles here. Now this is a wonderful thing, that receptor is maintained. So when PCSK9 in the endoplasmic reticulum is formed, and this PCSK9 comes in the circulation, so we estimate PCSK9 also in the department for our project, we discussed that because higher the PCSK9, higher the problem. So that means a gain of function. So this was this binds with the LDL, and LDL binds to the LDL receptor. This complex binds and this gets endocytized. Once is a endocytosis of this in a lysosomal, this gets destroyed. LDL receptor is degraded and there is no cycling. So anything which binds to the PCSK9, like evolocumab and erelocumab, these are the two monoclonal antibodies which are PCSK9 inhibitor and are wonderful drug. The science is perfectly good behind the development of this. Prevents PCSK9 interaction with the LDL, thereby increasing the recycling of LDL receptor, and more the LDL receptor, more the clearance of LDL, and the lesser the risk. If you see in heterozygous, this reduces the 60% reduction in LDL level, 39% reduction in severe phenotype, and consistent with duration reduction up to the 4 years. So in a homozygous, best response in a receptor defector. If receptor is defective in homozygous, this will work better. Otherwise, its effect will be lesser. Moderate response in autosomal recessive hypercholesteremia, no response in receptor negative mutation. So mutation receptor in LDL is important for the PCSK9 to prescribe. So route is subcutaneous. More PCSK9 like inhibitor like drugs are coming. This needs to be given more often. The drugs which are coming, they have a better pharmacokinetic and dynamic. LR100, some clinical trial, phase 3 trials are going on. Significant relative risk reduction. So that's important that when we give PCSK9, risk reduction, number of cardiovascular events are reduced. So lomitapide, and after this I'll enumerate the drugs only, then we'll say. So lomitapide is another wonderful physiology and pharmacology you see in a development of a drug. There is a microsomal triglyceride transfer protein which is expressed in endoplasmic reticulum of hepatocytes and enterocytes, and this can cause a significant 40 to 50% further reduction of LDL in a homozygous patient on standard lipid therapy. Standard lipid therapy is a statin and ezetimibe, and sustained efficacy up to 5 years of this drug has been seen. Now we see that if we give loperamide, this inhibits the MTP, that's the microsomal triglyceride transfer protein, and MTP is the one in the endoplasmic reticulum. It forms LDL in the hepatocytes and chylomicron in enterocytes. So when we see that, when we inhibit this MTP protein, these two are not formed. So number of maize have reduced. It was only 1.7 versus 21.7 in other group. Mipomersen, if we say, is a second generation antisense single stranded. So antisense molecule, oligonucleotide is a future of therapy, especially in dyslipidemia, and it binds to ApoB messenger RNA and transcripts in the liver and triggers its degradation. So ApoB, we know that is very important for the VLDL and the LDL molecule. If ApoB is more, LDL will be more. That is another surrogate marker. So if we decrease the ApoB, LDL and VLDL will reduce. So this is the thing, how this six antisense molecule in a DNA, there is a transcription to mRNA. mRNA forms the ApoB RNA. There is a translation and forms the normal ApoB protein product. So when we give the antisense oligonucleotide type mipomersen, this binds to the ApoB messenger RNA, and result of this, there is a degradation of the messenger RNA, and the byproduct, that is the ApoB, is not formed. When ApoB is not formed, so it leads to a decrease in the need of plasmapheresis is reduced. So the people requiring plasmapheresis, apheresis, is reduced, and 2 years of its benefit have been seen, but it was withdrawn due to hepatic and the cardiovascular thing. So bemopidine is the one which I told you that it decreases the TCS cycle and citrate formation. Citrate 2-acetyl coenzyme is not formed. HMG coenzyme will not able to work anything. So acetyl coenzyme A inhibitor, ATP citrate, and this causes, when this is not there, when the cholesterol is not formed, LDL is not formed, LDL receptors becomes upregulated. When receptors are upregulated, then whatever LDL is there is taken up by them, and levels comes down, and that is a target. Bempedoic acid is a drug which will be ruling the market in a next 5 years for the FH. So inclisiran is another drug which will be there, and it is already there in the market, and is a small interferon ribonucleic acid. So since time is less, and I have to wind up, I think I'll do that. So inclisiran, if we see the this picture, its mechanism will be clear. PCSK9, basically it inhibits the PCSK9 inhibitor. PCSK9 ज्यादा होगा, LDL receptor मरते रहेंगे. तो यहाँ तो PCSK9 का we block the effect or we block its production. So from where we can block the production? From the PCSK9 messenger RNA. So this cycle will be get break, and RIC, if we see when we get the inclisiran, it binds to ASPGR receptor, that is a acyloglycoprotein receptor, and then it forms the endosomes in a degraded, releases a SI neuron, small RNA, and then RISC complex is formed, result of which PSK9 messenger RNA binds to this complex, RISC complex. PCSK9 mRNA is blocked, and PCSK cannot be formed. So this is another drug which will be talked about and will be give some relief to the FH patients. So these are some of the studies. There's another target by which LDL and this lipoprotein lipase enzyme and endothelial lipase can be inhibited by blocking the PTL target, which is important for conversion of the VLDL to a VLDL remnant. So this aspect is inhibited when we block the PTL3. So this has shown the benefit. This is a gemcitabine, which is again a small molecule which enhances the clearance of VLDL by reduction of the hepatic ApoC3 messenger RNA. So gemcitabine, if we study in a study, it has seen that in the intervention of the first month, second month, and the third month, it was seen that the mean change of the baseline LDL was reduction in 26% addition to the other treatments. So this is a summary. Inclisiran siRNA inhibits PCSK9 synthesis, so it reduces LDL by 40% in heterozygous familial and 30% in homozygous, and injection site reaction is a problem. Evanacumab, that's a humanized monoclonal antibody which blocks the ANGPTL3 and reduces 49%. So influenza-like illness is seen as adverse effect. Gemcitabine enhances the clearance of VDL via reduction of hepatic ApoC. Like we have a ApoB, we have a ApoC3 also, which is required for VLDL further, and that is inhibited. And with this, in heterozygous, 40% reduction and 11% in homozygous has been seen. So gene therapy is another target which is coming up in a big way, and it has started from 1990, and we are here at the CRISPR and Cas genomic event, and the gene editing and a CRISPR, we all know that the way it is coming is to permanently correct the 3PS. Basically, it corrects its excise the defected part, and then it replaces with another, or it allows the natural healing of the defective SNP or the pluripotent cells are the thing which are really benefiting. Sorry, I covered last of the important drugs in a very hasty manner. It's a topic which is very important, and we should all get our LDL levels tested. If they are high, we should start working from today. So if there is any query, I'll be happy to have.
Thank you, Professor Rehan. The subject was so interesting and engaging that everybody wants the talk to go on and on and on, but there are limitations, so we have to bear with it anyway. It was a very nice presentation, and may we have some questions from the audience. Before that, I have just a small query. How frequent is this statin intolerance, and what are the manifestations mean?
See, statin intolerance is it's good. Indians, they are intolerant. We don't identify that it is intolerance. This is a problem. Our compliance to the, in our study in our department, where Dr. Lalit was also with us, we found that only 60% of the patient takes their medicine. 40% they don't take at all. Compliance is not there. And when the compliance is not there, you believe that the people, those who are not taking, they are intolerant. Maybe initial phase of the muscle ache, they stopped, or the financial matter reasons for stopping the treatment. Yes, it's a problem. It's a problem, statin intolerance, but we have to identify. Like if we start with the atorvastatin and there is a muscle ache to a severe extent, LDH is increased, CPKB is increased, and really patient cannot tolerate it, then go to a higher drug. Start with a rosuvastatin. The intolerance is less with the rosuvastatin as compared to this. So, but before we label the patient as an intolerant, we have to reduce the dose of the atorvastatin. If the patient is on 10, reduce to 5. And if still the symptom arises, then you switch over to another. Without this following this criteria, we should not label the patient as an intolerant. But invariably, in patient, they do tolerate one or the another. If you see the pitavastatin, patient tolerates even better than the rosuvastatin. So 4 milligram pitavastatin, patient, they really do good. Cost factor is there. Now rosuvastatin is easily affordable by the patient and is included in even an LEM. We have a rosuvastatin in hospital formulary. We do have a rosuvastatin. And plus the pleiotropic effect which the statin have, that also gives the benefits.
Any other question? So no more questions. Thank you again, Dr. Rehan. And I request my co-chair, Professor Lalit Gupta, to introduce the next speaker.
Thank you.
Thank you.
Our next speaker is Dr. Arun Gupta. He is the founder of Ayush Swasth Private Limited, Faridabad, co-founder and director. Yes, and he has earlier worked as head medical affairs and clinical research at Dabar, senior manager medical and regulatory affairs at Clinirex, and medical advisor at Cystopic. He has not mentioned that he has also worked as senior resident in Rohtak and lecturer also. And he has rich experience in herbal drug development and clinical research and regulatory affairs. He has participated as so don't go by his looks. He is a young and dynamic person, though nowadays it's Akshay Kumar look which is popular. So and he has won Servier's Young Investigators Award for his work on Asa Directa Indica. He has worked in various phase 2, phase 3 global clinical trials. And of course, numerous publications who are highly cited in national and international journals. So we welcome Dr. Arun Gupta and look forward to his talk on clinical research in India and a regulatory and scientific overview.
Thank you so much, Dr. Lalit, for the kind introduction. And thank you, Dr. Monica, for giving me a chance to, after inviting me here, so that I can share my thoughts on it. And Dr. Lalit, sorry, I didn't mention Rohtak. It was not intentional. Definitely, Rohtak is core inside me. I am the proud alumnus of Medical College Rohtak. Thank you anyway. So today, my talk is basically to give some of the specific regulatory and scientific perspective about the clinical research, mainly in India, but we'll try to cover the global perspective behind it in nutshell because time will be limited. So I will just try to cover. And topic is, I have prepared in a way that it is very, very useful and fruitful for my very, very near and dear people who are not on the front, rather they are sitting somehow on the back sides, but they are more important people for my talk today. So I request all of you to be attentive for around 20 odd minutes with me, and you will gain out of it. The practical exposure behind it you will gain, which is not written in the books, many of the aspects. That's the point. So before giving any background of the clinical research and all that, I understand all of us know those type of background, informed consent, how drug develops, this, that. I straightway come to the regulatory aspect. And before coming to the Indian regulatory part per se, definitely I would like to touch up this ICH. All of us know that ICH is a global guideline making body, and 3 reasons were involved in that: US, Japan, and Europe, who had taken that initiative and made beautiful guidelines. And they had made many, many guidelines. And these guidelines were mainly encompassing safety, quality, and efficacy. And as far as the various guidelines are concerned, they are covering the drug development pathway full, not only clinical research per se. If you see quality, we'll talk about all the GMP and every type of stuff. Safety is mainly of the preclinical safety, not the clinical one, because efficacy will come in E, but clinical safety will also come in E only. So efficacy will take care of the safety, efficacy in human, and multidisciplinary things will be taken care of. But now coming to the Indian part, which is the core of the topic for today. We know Drug and Cosmetic Act and rules. We know CDSCO is the central body, Central Drug Standard Control Organization, which is headed by DCGI, Drug Controller General of India. All of us know that. And NDCTR is the current regulation. Schedule Y used to be there earlier, but now 2019 onward, it is NDCTR, which is in place. And ICMR guidelines, of course, they are beautiful guidelines. As far as ethics is concerned, I have gone through many, many guidelines, including Declaration of Helsinki and many, many more. But ICMR has beautifully covered almost every aspect of the ethical aspect behind clinical research. So I request all of you, my dear students and colleagues sitting behind, you must go through this document in detail, if you really want to see the ethical aspect of these clinical research. And of course, Indian GCP, CTRI is mandatory. I will not go into these details. What is GCP and all? You know, they are basically standards for the design, conduct, performance, interpretation, all the aspect of the clinical research, everything will be taken care within the GCP. But the 3 things definitely I would like to touch up. As far the principles are concerned behind GCP, the core 3 pillars of the GCP are the ethics, and within ethics, I will touch up protection of human rights is the main pillar. And of course, science, if I say integrity and reproducibility of the data, whatever data is there. And of course, compliance. If compliance is there, then only a quality study will be there and the quality data will be there. And just the background of the GCP adoption, just to give you that 1996 started, and India is also part of that. Indian GCP is also in place now. ICMR ethics guidelines, as I was saying, it is available online. And this covers mainly all the general principle, ethical issue, conduct of research, ethical review procedure, informed consent process. I will not just enumerate, but these are the major chapters within these guidelines. And CTRI, as I was saying, it is a mandatory requirement today. It is just an online portal, very easy to register, just like an email, and then we can register our trials. It started in 2009 actually, when it was advisory, but somehow regulators saw that industry or the academicians, they were not doing any trial registration. Then they made it mandatory in June 2009 itself, within the same year. And even today for Ayurveda, Siddha, Unani drug, it has been mandatory from 2013 onward. This is just an official site snapshot. As well as Schedule Y, we will not go into detail, seeing the paucity of the time. But the point is, the latest amendment is 2019, which is NDCTR, New Drug Clinical Trial Rules. 2019, we must follow 2019 NDCTR only while doing clinical research. We cannot go to the Schedule Y and the earlier versions of the Schedule Y. As per this gazette, it was notified. Yes, within this law now, academic clinical trial has very conspicuously been mentioned and elaborated, which was not there earlier. So, though it was mentioned, now they specifically mentioned what to be considered as academic clinical trial, because many people here are from the academics and many of us might be in the academics down the line. So any new indication of the existing drug and any observation or something like that, but it must not be for promotional or commercial purpose. That is a basic caveat behind any drug if you want to say academic clinical trial, because many a time as an industry, we have found that industry come to us in clinical somewhere, they say you do this study as an academic clinical trial, and but in background actually it is a commercial which is there. So that must not be considered academic clinical trial, because sponsor is the pharma company there. Then it is a sponsored clinical trial. EC approval definitely still will be required. CTRA registration still will be required. All other processes will be required. Only difference will be DCGI approval will be waived off or may not be needed. That's the only difference. A new drug, we know which are new drug. I will not just enumerate, but just one point, that any new chemical entity which has been discovered in India, it's very peculiar that up to 4 years, it will be considered new drug. Let us say I am an industry, I have launched a drug after doing all phase 1, phase 2, phase 3, taken DCGI approval, launched the drug. Usually in majority of the country, it's no more a new drug. But now another of my competitor, another of my friend, another of my competing industry or any other company wants to launch it. Up to 4 years, still it will be considered new drug only, and they will have to follow the new drug processes only. They cannot say it has already been launched. They cannot say it is already available in Indian market. And of course, vaccine, DNA-derived product, xenograft, gene therapeutics, they will always be considered new drug. This vaccine and this modified dosage form is very peculiar in Indian law, that they will always ever be new drugs as per our law. And new drug processes has to be followed for these things. This is a new chapter in our current NDCTR 2019, which is BHR. Previously, it was not very clear that all those drugs which are not falling under you can say new drug per se or under regulatory domain, what to do. Now it is very clear what type of ethics committee, how to take approval, how to give compensation, and there are specific guidelines for these type of BHR, biomedical and health research. There are specific timelines today, that 13 working days the timeline if that molecule is being developed in India. But if it is a molecule which is being developed by some multinational company or some academics, whatever, outside India, these 30-day timelines no more works. We can just leave it. Sugam portal is there just to show you that previously so many things were offline. within the DCGI, CDSC or Central Drug Standard Control Organization. Now it is very streamlined, very smooth. Sugam portal is there. All of my clinical trial application, all of my assay submissions, all of my protocol submission, amendment submissions, everything is going through Sugam, be it even clinical safety report, DSUR, PSUR, annual safety report, everything is going through Sugam only. I don't have to go to DCGI with a hard copy of papers, because that was very, very tough for global clinical trials, especially. Application is done in form CT04. I will just skip all these things like name of the drug, manufacturer, patent status, pharmacology, all the clinical trials, all the data, whatever it is, of course, has to be submitted online while taking clinical trial approval. And fee structure is clearly mentioned now. Phase 1, it is 3 lakh, phase 2, 2 lakh, phase 3, 2 lakh. But if it is an MSME, if the smaller company is registered into MSME, then the fee structure will be different, and that will be half. And for the orphan drugs have been discussed in the previous lectures, and then this is totally waived off. No fee will be taken for the clinical trials on the orphan drugs. And test license, of course, is required. Specific forms are there. We can just skip them. Export license is also required, especially in the global clinical trials, because we cannot ship biological samples like urine, blood, plasma, everything. They will fall under restricted items as per our DGFT policy. So we will have to follow the law. We will have to take the license before shipping it to Switzerland, Europe, or wherever we want to send it as a central laboratory assessment, if that laboratory is sitting outside India. We will just leave it, but there is a specific undertaking by the investigator as per our law, where 10-15 clear points are there for what I am undertaking. Yes, if I am doing this clinical trial, I undertake this, I will follow protocol, I will report assays, I will take care of the patients, I will do this, I will do that. All the things are very clearly defined, and all these things has to be signed off. Audio video consenting today is there. Previously it was made just mandatory, but now they have bit relaxed it. They have said it is absolutely must for the vulnerable subject in clinical trial if it is done on the new chemical entities or new molecular entities. However, for anti-HIV and anti-leprosy, considering the social stigma, especially the countries like India or any developing country for that matter, people were not ready to give video. So it was now relaxed that they can only audio recording is okay for leprosy and HIV patients. No video is required. And assays, of course, we know death, life-threatening, hospitalization, persistent, significant disability, incapacity, or the congenital anomaly. They are the 5 typical criteria. So they have to be reported in defined timelines. Timelines are very, very clearly mentioned, not only for the investigator, not only for the sponsor, for ethics committee, for DCGI office, for each and every, very clearly defined. Like investigator within 24 hours, sponsor within, say 14 days, ethics committee within 30 days to tell how much compensation is required. Then DCGI will give to expert committee within 60 days, and then expert committee will tell within 90 days. The CLA, Central Licensing Authority, that is DCGI. So very, very clear defined timelines are there today. And very clear formulas are there for the compensation in case it is there. I have just taken one case of the death case. However, for hospitalization, there is a separate formula, and other assay, there is a separate formula. This is just a formula, BFR divided by 99.37, and be the base amount is that. We will not go into those details, but in general, it may range from 2 lakh to 73 lakhs for one death case. So wherever we are involved in the trial for that sponsor, we have to highlight this point many a time, especially Indian companies. I am not criticizing them. They're not very well versed about these laws. And then suddenly they have said, you have to give 73 lakh for this death. They say, we are doing this trial for 50 lakhs. You are asking me 73 lakh for one death. How can I give? So we must tell them either you take insurance or something, but they have to take care of this aspect. This is the law. Of course, all the SOPs should be in place before doing any clinical trial. Ethics committee, of course, there are 2 types of ethics committee structure mentioned today by DCGI as per the law. One is which is approved by DCGI, one which is the other one which is approved by the DHR department. So non-regulated studies has to be approved by the ethics committee, which is approved by DHR, and all regulated study has to be approved by that ethics committee, which is registered with DCGI. So this is very clearly defined today. And of course, composition and all that, 7-member chairperson. But these couple of points I would just like to touch up, because the global regulations say that they do not talk about the chairperson has to be from outside. In Indian law, it is very clear that chairperson cannot be from the institute. Might be they have realized that, we are not very good people per se within the institute as a core group type of. So it's a good thing. If chairperson is from outside, probably biases will be much lesser. And of course, members are much more. 7 members, usually global level they say 5 members are enough. Here it is 7 members, and so many some other things are there and other differences are there. For basic quorum also they have given the things. Informed consent, I have just touched that informed consent is a mandatory requirement. Written informed consent, which has a full-blown process, which we cannot touch up in detail in this small presentation. Design, of course, it is very clear that as far as possible, try to do multi-centric. 2 minutes? Yeah, sure. And as far as possible, try to be across centers, and then it has to be randomized as much as possible or blind. So RCT is a gold standard design, and monitoring has to be there as per our law also. Without monitoring, trial has no meaning. Just 2 points I will touch up, MEDRA and HUDRA, which are very critical. Most of the time, Indian studies, we have seen that they are not using MEDRA and HUDRA, because MEDRA coding, until unless we do coding, let us say my patient, few patients were having pyrexia, few patients were having fever, few patients were having high temperature, few patients were having temperature, but all of them are fever only. So until unless I code this to fever or pyrexia, my results, I will not get the way they should be. So MEDRA coding is very, very critical. They were started again, US, and Japan and Europe. And today we are using in all of our study, including especially in global studies. And HUDD is also very important for all other events which are not given in the MEDRA, especially the drugs. If I have taken, say, paracetamol, I have taken crocin, I have taken calpol, all of them are same. Until there is a coding to paracetamol or whatever is the generic name, then my data will not be the way it should be. So HUDD coding and MEDRA coding is very critical. And key document, of course, all of us know protocol, ICD, ICF, IB investigator brochure, and IFPD investigational medicinal product dossier. Why I'm touching this? So that we can discuss what are the key documents which will fall under the major amendment. If I do any change, as per our law, if there is any change in the age limit of subject, dose, treatment, and duration, and any increase in the number of subjects, any amendment in study design per se, inclusion exclusion criteria is changed, or safety or efficacy parameters are changed, or any other change which has impact on the safety of the subject, then it has to be submitted as a major amendment. It must be approved by DCGI. All others will fall under minor. Any change in IMPD, any change in ICD, any change in CRF, any change in IB will fall under minor only. No approval is required, but we have to notify. And if I am doing just a couple of slides, additional requirement for any global clinical, if I am involved in the global study, global clinical trial, though I have to take care of all those type of stuff, but I have to use a validated software to enter my data. If it is EDC, might be non-EDC. It has to be validated. ICH GCP is a must to follow. Along with investigator undertaking, I have to fill up as an investigator form 1572 if IND molecule is there or USA is involved. Financial disclosure statement, I have to fill up 3455 for USA. India, in India, in my Indian investigators who are involved in that global study. Import license, probably I have to give because my drug might be imported from Switzerland or something. I have to take DCGI approval for import license. Export license, previously we used to take from DGFT. Now today it's a single window. We are applying to DCGI only. It's a good thing for us, smoothen the thing. For exporting the biological sample, we cannot export for testing the biological sample outside India because it is considered restricted item as per our law. And USA MedWatch and other countries SIOM safety report. So there are few requirements. So I think this is just my last message that we should take care and we should participate only in the ethical and the legal research and the conduct should be as per GCP, NDCTR, and all other applicable guidelines. And of course, document. Because if not documented, we say it is not done. So this is just my last words. Thank you.
Oh, thank you, Dr. Arun Gupta. It was a very engaging, very extensive talk. We usually need 5-day workshop for imparting this knowledge, but I could not see any point which was missed in your presentation. So again, it was excellent, and yet we needed more time. And now I request my co-chair to give some concluding remarks.
Thank you, Dr. Arun, for taking up this important topic. And I'm sure today and in future, the points that you highlighted, and at the beginning of the talk, you said that these things will not be found in books. And you're perfectly all right in saying this, that these things which you highlighted are not given in the books, because this is your hands-on experience which has talked today, not the books. And our students and clinicians must have learned a lot from this talk. Thank you.
Thank you so much.
I request the sir to please be on stage, and I request Honorable Chairperson to please felicitate our speaker. I also request Dr. Sujata Gautam to please felicitate our chairpersons. I request Dr. S.K. Vajpayee to please be on the stage for the felicitation. Our esteemed chairpersons, Dr. S.K. Vajpayee, Dr. Lalit Gupta, and Dr. Monica Verma. Dr. Lalit Gupta. Dr. Monica Agarwal. Before proceeding towards the next session, just to break the monotony and to keep the mood light and bright, we are now proceeding towards next thing. I would like to ask audience that how many of you have watched the movie Bagban? The movie Bagban by Amitabh and Hema Malini. I would like to know who all have seen the movie. Okay, so we have great number of audience who have seen the movie. So I'll be asking 3-4 questions, and the rules are very simple. Please do not be impulsive to answer before listening to the options. One who does that will be disqualified. So the first question, including Salman Khan, how many kids did Amitabh Bachchan have in the movie? Please do not answer without raising the... Including Salman Khan, how many kids did Amitabh Bachchan have in the movie? Your options are 6, 4, 3, 5. I would request Pravina ma'am to please look who is raising the hand first so that we can have fair play, right? So once again, I'll repeat the question so that you can raise hands again. Please, before, before listening to the options, if you're raising hand, you're disqualified for sure. Ma'am, please have a look who's raising the hand first. Including Salman Khan, how many kids did Amitabh Bachchan have in the movie? Exactly, it was a trick. Whoever raised the hand is disqualified. So now I present the options. First option is 6, second option is 4, third option is 3, and fourth option is you're disqualified, ma'am. Fourth option is 5. You please stand up and embrace us with the answer. 5, how many of you agree with her answer? She's absolutely right. Congratulations. Next question, bit difficult from the previous one. At what station Pooja and Raj meet after 6 months? I have the options with me. Vijayanagar station, Mangalore station, Chhatrapati Shivaji terminal, and Howrah railway station. Please tell them. Correct. The answer is Vijayanagar station. What is the name of the book written by Amitabh Bachchan during his separation from his beloved wife? Your options are Khalistan, Parivar, Imtihan, or none of these. If you say none of these, you need to give me the answer also. Exactly, yes. Next question. Amitabh Bachchan's eldest son was Ajay Malhotra, and he was actually Aman Verma, who was offered the role before. Before him, the role was offered to somebody else. Your options are Arshad Varsi, Bobby Deol, Vijay Ras, Monish Bahl. Please raise your hand before answering. Yes, ma'am. Ma'am, raise the hand, Dr. Sudha. Yes, ma'am. The answer is Monish Bahl. Please, loud applause for ma'am. Next question, I would prefer without option if you answer. Paresh Rawal calls Amitabh Bachchan by which term? Sir, how do I ever disqualify you? Exactly, the answer is Mota Bhai. I have another, in that question, I had an option called bro also, which is for sure, I think, related. So last one difficult question. What is the Bagban movie is an unofficial adaptation of a play? The options are Footlight Paradise, Make Way for Tomorrow, 1 Hour with You, and Becky Sharp. You can just make a guess, I know. The game changer question. Bagban is an official adaptation of Footlight Parade. Who thinks it could be Footlight Parade? Make Way for Tomorrow. Who can think it's Make Way for Tomorrow? 1 Hour with You. Becky Sharp. The answer is Make Way for Tomorrow. So with this, we proceed towards, do we have any winner? I think every yes, sir. Agreed with this thing. Thank you, sir. Thank you, sir. Thank you so much. Now we proceed to another intellectual session. It's R. Srinivasan Prize. The judges for the same will be Dr. S.K. Vajpayee, Professor and Head Department of Physiology. Sorry. I'm very sorry. Dr. S.K. Vajpayee, Senior Professor Pharmacology, former Dean, Government Medical College, Surat, and Founder President, Indian Society of Hypertension. I really apologize for the wrong introduction, sir. I'm introducing you on this stage for 8th time, and I'm still doing mistakes. So I am apologetic twice, thrice, sir. And also the next judge for the following will be Dr. K.K. Deepak, Professor and Head Department of Physiology, AIIMS, New Delhi. I request the audience to welcome our judges for R. Srinivasan Prize. Big applause. Since this is a competitive event, I would like to please announce the rules for the contestant and also for the judges as well. You will be given 8 minutes to speak, and the question answer round will be strictly for another 2 minutes. In the last minute of the session, you will be given a warning bell, and in the last 1 minute, you have to wind up your presentation. Contestant exceeding 8 minutes of duration will be penalized for sure.
कौन सा आपका ये ना
Good afternoon, everybody. Now, I just noticed there are 5 contestants, and one of them happened to be my student. So, in all the interest of the ethical consideration, I would like to withdraw, and so there's no conflict of interest. And I'll request organizers to suggest alternative name as judge for this session.
आपका
Okay, thank you.
ये ना yes and
I request Professor Neelam Bani to judge for the R. Srinivasan along with Dr. S.K. Bajpayee.
One second, okay. Revant. Revant, no? Okay.
Are we supposed to call the chairman? Is there any chairperson for the session?
Anybody else is the speaker in this? Come.
So let us start.
Yeah, in this way is it?
Let us
Nikita?
check whether all these participants are
change
there,
it's here.
present. Swati Bansal. Okay. Ravan R.
Okay. I put it here now. Okay.
Is he present?
Anybody else besides this?
You miss BHU, Ravan R. Is he present or not? Is there? Is there?
Deep Shikha.
Yes.
Okay, okay. Then Jeel Ajola.
Yes.
Fine. And Mansi Jain.
Just 1 second.
So, first participant is Swati Bansal from the Maulana Azad Medical College, and the title of her presentation is Effect of Raj Yoga Meditation on Cognition and Quality of Life of Young Adults with Internet Addiction. Please,
This is yours, no?
and mind the time, please. Huh? This is a competition, prize session. I think you have 8 minutes for presentation.
Yes, sir.
Yeah.
Should I start? May I start, sir?
Please go ahead.
A very good afternoon to our esteemed judges, all the dignitaries as well as delegates. This is Dr. Swati Bansal from Maulana Azad Medical College presenting my paper on the topic Effect of Raj Yoga Meditation on Cognition and Quality of Life of Young Adults with Internet Addiction. Proceeding with internet addiction, it is defined as a psychological dependence on the internet, regardless of the types of activities that we pursue after logging in. In 2013, internet addiction has also been included in Appendix 3 of the new version of Diagnostic and Statistical Manual for Mental Disorders, that is DSM-5, as internet gaming disorders. Some studies done in United States and Europe suggest global prevalence of internet addiction to range from 1.5 to 8.2%, while in Southeast Asia, the prevalence among young people might be as high as 20 to 30%. Problematic internet use has been associated with cognitive impairments as well as impaired quality of life. While meditation holds a positive correlation with control of internet addiction as well as an improvement in cognition and quality of life. And Raj Yoga meditation is one such type of meditation, which is a spiritual process for helping us understand ourselves better and control the body using the power of mind. Aim of our study was to assess the effects of Raj Yoga meditation on cognition and quality of life in young adults with internet addiction. The study was conducted after obtaining the approval from the Institutional Ethics Committee of Maulana Azad Medical College and Lok Nayak Hospital, New Delhi, with study design being prospective interventional study period being 1 year, and the outcome variables were cognition and quality of life. For the estimation of sample size, it was determined for a repeated measures analysis of variance within between interactions using a priori power analysis via GPAR 3.1 raised to the power 19. The power analysis was conducted using two groups for an alpha level of 0.05, a power of 0.8, and a small to medium effect size of 0.25, and a non-sphericity correlation coefficient of 1. Using that, desired total sample size was calculated as 28 subjects, that is 14 subjects per group. But since high attrition rates are common amongst longitudinal studies, which could lead to research bias, we recruited additional subjects over and above the calculated sample size, that is 20 in each group. Our study population consisted of young adults, that is undergraduate medical and paramedical students, resident doctors, nursing and laboratory staff that were lying in the age group of 18 to 30 years from Maulana Azad Medical College and its associated hospitals. To be included in the study, the criteria was age group 18 to 30 years. Those that had internet addiction that was determined by a score of more than 30 based on Young's internet addiction test, and who were also willing to practice Raj Yoga meditation for 8 weeks. Excluded from the study were anyone who was already practicing meditation for more than once per week for the past 3 months, anyone who is suffering from any acute physical or mental illness, or who were on any medication that could likely affect cognition. So this is how we proceeded. We took 40 healthy individuals and took their socio-demographic profile and internet usage data. Then we assessed internet addiction using Young's 20-item internet addiction test, and based on that, we categorized them into mild, moderate, severe addiction, or no addiction. Those who did not, those with score less than 30, less than or equal to 30, were not having any addiction, and they were excluded from the study. After this, the participants were randomly allocated into Group A and Group B, that is control and meditation groups. Baseline readings of World Health Organization quality of life and Montreal Cognitive Assessment questionnaires were taken. After which Group B, that is the intervention group, practiced Raj Yoga meditation for 20 minutes per day for 8 weeks. And then readings of internet addiction test, WHO, QOL, and MOCA questionnaires were taken again at 1 as well as at 8 weeks. This is the flowchart depicting the same. The data that was collected was entered and analyzed with SPSS software package using appropriate statistical tests. In results, we can see that the two groups were comparable in terms of age, gender, and levels of their baseline parameters, as can be seen using p-values. Like this table is showing. the comparability of the two groups in terms of age, in terms of gender, as well as number of hours spent on internet. P-values being non-significant, showing non-significant differences. And this is the table showing baseline parameters of Young's Internet Addiction Test Score, World Health Organization Quality of Life Score, and Montreal Cognitive Assessment Score, which again shows the two groups were comparable at baseline before any intervention were given. Now coming to Young's 20-item Internet Addiction Test Score comparison, we can see that the two groups were comparable at baseline, while they showed significant difference in their internet addiction score after 1 week and after 8 weeks of meditation. And also, Group B showed significant reduction in internet addiction test scores at 1 week as well as at 8 weeks, p-value for both being less than 0.0001. Coming to Montreal Cognitive Assessment Scale score comparison between two groups, we can see the groups were comparable at baseline as well as at 1 week, and there was no significant change at 1 week in both the two groups, while it showed a significant increase at It showed a significant increase at 8 weeks in both the groups. Coming to World Health Organization Quality of Life Score, the values were comparable at baseline as well as at 1 week, while there was a significant difference between them at 8 weeks. And also it increased significantly only in Group B, that is in the meditation group. So we can conclude that that there was a significant decrease in internet addiction after short-term as well as long-term meditation, and also an improvement in quality of life as well as cognition after long-term meditation practice, based on which we can suggest that institutes of higher education, where usually this students belong to this age group, can include meditation practices to support student self-care. Thank you. Thank you, everyone.
Just one question.
Yes, sir.
Have you taken the permission of the ethics committee?
Yes, sir.
You are not mentioned.
Mentioned, sir. Yes, sir.
So can you tell me in brief, in 1 or 2 lines about the Raj Yoga meditation, how you perform?
Ma'am, Raj Yoga meditation is actually the subject is asked to sit in consciousness with their eyes open, and they are asked to fix their gaze on a specific object, which can be a spirit, like a symbol or something, and it is practiced in 4 stages. That is initiation, where they are asked to sit comfortably and quietly, and then they are asked to meditate. Second step is meditation, where
so this practice was done in your department, or they were asked to do at home?
We did it online. A few sessions were guided sessions. Initial few sessions. Initially, we did 3 sessions guided sessions online. By creating Zoom link, and after that we asked them to practice it every day, continue doing it every day, while also taking guided sessions twice weekly.
Online.
Yes, sir. Online. Sir, Sir, actually, one of my co-guide is a Raj Yoga teacher. So she was like guiding, she was telling, and she, after that we gave them videos through which they could practice. Yes, sir. We asked them to. Thank you, sir.
Thank you, Swati.
Thank you. Thank you.
So I would call the next speaker, Revananda.
Which is a presentation.
A very warm greetings to one and all out here. I am Dr. Revandar, third year junior resident from the Department of Physiology, Institute of Medical Sciences, Banaras Hindu University, Varanasi. Today, I would like to present my research work titled Histamine-induced vasosensory reflex responses are mediated by perivascular receptor-level crosstalks in anesthetized rats. So to begin with, what are these vasosensory reflex responses? Whenever a chemical nociceptive agent is instilled into a peripheral blood vessel, preferably an artery, the perivascular sensory nerve endings get activated and they carry the information of local tissue damage through the ipsilateral somatic nerves to the pontomedullary centers of the brain. These pontomedullary centers of the brain then regulate the cardiorespiratory parameters in a reflex fashion. So the cardiorespiratory responses, reflex responses that are evoked by the presence of nociceptive agent in the peripheral blood vessels are called as vasosensory reflex responses. The aim of the present work was to identify the perivascular receptors that are mediating the histamine-induced vasosensory reflex responses. To do this, after obtaining the ethical clearance from the institute, we procured adult male albino rats of Charles Foster strain and anesthetized with an intraperitoneal injection of urethane. Once the animals were sufficiently anesthetized, we did tracheal cannulation to reduce the respiratory distress to the animal. After that, the area of right femoral triangle was dissected to skeletonize the femoral vessels. Once the femoral artery was isolated, we cannulated the femoral artery using a 24-gauge double-ported polyethylene cannula, which was designed in our laboratory. Now, the special thing about this cannula is that it had two ports. One is the vertical port and the other is the horizontal port. The horizontal port here was used to instill the algogen into the femoral artery. Here it is histamine. And the vertical port. The horizontal port was connected to a BP transducer for recording the BP continuously. Now, this cannula was an improvement from the earlier methods because in earlier methods, carotid cannulation was used. And when we do the carotid cannulation, the blood supply to the pontomedullary centers could be hampered. And these centers are the ones which are going to cause this reflex cardiorespiratory responses. So this is a schematic diagram of our model. So here we can see the double-ported cannula, which is used to deposit the algogen in a narrow segment of the femoral artery. And the same horizontal port was connected to the blood pressure transducer to record the BP. A force transducer was used to record the respiratory movement, and needle electrodes were used to record the ECG, from where heart rate was derived. Coming to the results, in the initial concentration response experiments, we observed that instillation of histamine evoked a transient tachypnic, hyperventilatory, hypotensive, and bradycardiac responses, which could be seen here. So from these response pattern, we concluded that 10 millimolar evokes an optimal response because at higher concentrations, the response pattern changed drastically. In the other subsequent experiments, we tried tracing the afferents and efferents of this reflex responses by doing a ipsilateral sciatic and femoral nerve sectioning. So here in this diagram, the sciatic nerve is dissected out, which was transected later. And in this diagram, we can see the bilateral vagus, which were dissected, which was transected later. So in all the two groups, the neurotomy group and the vagotomy group, the responses were abolished, indicating that the possible location of afferents and efferents could be in these nerves. Now, to identify the possible origin of these reflex responses, the perivascular area was locally pre-treated with lignocaine. So lignocaine is a local anesthetic agent, and this also completely blocked the response. Now, to identify the receptors that may be involved in producing these responses, we pre-treated 4 separate groups of rats with capsazepine, which is a TRPV1 receptor antagonist, phenyramine histamine receptor antagonist, ondansetron 5-HT antagonist, and diclofenac, which is a cyclooxygenase inhibitor. And we can see that in all the 4 groups, the tachypneic, hyperventilatory, hypotensive, and bradycardiac responses were significantly attenuated. This shows that even though we are using histamine as a nociceptive agent, the receptors that are involved is a mixture of receptors. So I would just summarize like this. Whenever we are instilling histamine into a peripheral blood vessel, it activates the perivascular nerve endings. The afferents of these signals run in the ipsilateral, sciatic, and femoral nerves, go to the pontomedullary centers, which regulate the cardiorespiratory parameters in a reflex manner. The efferents could possibly lie in the vagus nerve. And there are a group of receptors which are involved in mediating these receptors, which are the sodium channels, perivascular sodium channels, cyclooxygenase, 5-HT3, TRPV1, and the histamine receptors. Now, how can we conclude this? We are discussing about the nociceptive reflexes. That is, whenever there is a tissue injury in the periphery, these signals has to be sensed and taken to the central nervous system. So, availability of multiple receptors serves as a safety factor and provides a redundancy. That is, if one receptor system fails, the other receptor system can take over and then it can signal the CNS appropriately. So these cross interactions are known to appear at the level of the second messengers in the level of the endothelial cells, as can be seen in this particular figure. So these are the articles that we were able to publish from related to this work. I thank the Apicon team for providing this wonderful opportunity to present our work in front of you. Thank you, sir. Yes, sir. Whenever there is a tissue injury, whether it is a traumatic injury or an infective etiology, there is a release, a local release of inflammatory soup. And this inflammatory soup is a mixture of histamine, serotonin, bradykinin, and ATP and the other substances. Now, in an acute phase, the reactions caused by these inflammatory soup is not so prominent. But over a period of time, in chronic inflammations, these inflammatory soup adversely affects the cardiorespiratory system. So this effects that we are seeing in rats can be extrapolated to the humans also in the case of acute and chronic inflammations.
So like you had told about perivascular receptor level. So that was, can you show me the slide?
This one.
That was, yeah. So can you brief again?
Yes, ma'am. So here in this corner, they have shown, it is from a article, a review article, which we have used as a reference. So here the G protein coupled receptor of inflammatory components of inflammatory soup, that is histamine, serotonin, bradykinin. Now we know that histamine acts on histamine receptors and it could produce physiological effects. But here is a pathway which shows histamine acting on the histamine receptors through the second messengers go and cross activate the TRPV receptors also.
What about the blocking agents? They are acting at this level only? Or?
Yes, ma'am. They are acting at that level. Suppose if we are giving capsaicin, it will block the TRPV1 receptors, and that is why the responses are reduced, though they are not completely abolished.
And what about the other blocking agents which you have used?
The others at the respective levels, ma'am. Suppose ondansetron at the serotonin receptor level, histamine blockers at the histamine receptor level, like that. Thank you. Thank you, ma'am. Yes, sir. We require different blockers. No, sir. There is no one such substance which could block everything, but we can. Thank you, sir.
दीपिका, तुम्हारा कौन सा ये है ना? ये है ना?
Should I start? So should I start? Good afternoon, respected judges and all the delegates. Myself, Deep Shikha, MSc student, Department of Physiology, AIMS Jodhpur. I am going to present my work on psychophysiological correlates of performance in the NBAC task, reveal the stress suppressing effect of citrus odor. Stress has a detrimental effect on cognition. According to many studies, we have seen the presence of stress has impaired the cognitive performance. Stress also affects the autonomic nervous system that is helpful in attaining an adaptive behavior and is also responsible for the time-consuming and cognitive task. So in that regard, olfaction comes in role. Olfaction, with its close association to the limbic system, provides us a suitable pathway to study stress and stress-related responses. According to studies, it has been shown that repeated exposure to olfaction mitigates the stress. So I hypothesize that olfactory stimulation will improve the cognitive performance by managing the stress, which can be assessed by the autonomic parameters. We aim to study the effect of olfactory stimulation on cognitive performance and autonomic parameters with the objectives to investigate the effect of citrus odor on performance in the two-back task and to assess the effect of citrus odor on electrodermal activity, photoplethysmography, and heart rate variability during the two-back task. As there is scarcity of data regarding the association, we are here trying to find out the association between olfaction, stress, cognition, and autonomic parameters. So we designed an interventional study that was performed in the Cognitive Neurophysiology Laboratory, Department of Physiology, AIMS Jodhpur. 30 healthy male subjects between age 20 to 45 years were included in our study. Following the convenient sampling, subjects who were having upper respiratory tract infection, history of chronic medical illness, history of traumatic brain injury, current use of drugs that affect the cognition such as sedatives, excessive sweating, and any known allergy to odor were excluded from our study. Ethical approval from Institutional Ethical Committee was taken and written consent was taken from all the participants. Starting with the experimental protocol, we have obtained a perceived stress score and mini-mental status score from all the participants who were recruited in our study. The experimental protocol was performed in 2 sessions. First control session and then an experimental session with a rest period in between. Both these sessions were done in morning half on the same day. Subjects were presented with the two-back cognitive task that assess the working memory of the patient, of the subject, and during the task, we have obtained the physiological recording of electrodermal activity, photoplethysmography, and heart rate variability, in addition to a 5-minute baseline recording that will be later considered as a delta value to compare the change in the physiological parameters. Citrus odor was used as an olfactory intervention in the experimental protocol. This is the two-back task that was designed using SuperLab 5.0 software in our lab. A total of 120 targets, a total of 120 events, 30 target and 90 non-target events were used. The listed below are the autonomic nervous system parameters, electrodermal activity for sympathetic response, photoplethysmography for pulse waveform, and lead to electrocardiogram for heart rate variability were checked. This is the representative recording of the physiological recording using BioPack 150 module in our lab. These are the sessions of the task performed. As you can see in the figure, 2 sessions were done, control session and experimental session. The subject is performing the task, NBAC task, and along with the physiological recording of EDA and PPG. And in the experimental session, you can see the odor diffusion. Coming to the result, 30 participants were analyzed with a mean age of 28.3, with a mean perceived stress score of 15.9, with a mean mini-mental state score of 28.7. Coming to the cognitive task, the performance in the 2-back task has shown significant result, significant improvement when citrus odor was given to the subject in the experimental session. Target response number, percentage accuracy, and missed target response shows a significant improvement in the presence of citrus odor. Coming to the HRV parameters, we have taken delta RMSSD, delta PNN50. This delta is the change from the baseline to the control session recording and from the baseline to the experimental session recording that we have discussed in the experimental protocol. So the delta RMSSD, delta PNN50 has shown significant improvement when citrus odor was given. Delta HF power, that indicate the frequency domain of the HRV parameter, have also shown a significant improvement when olfactory stimulation was given in the experimental session. Changes in the SDNN, total power, LF power, and low frequency high frequency ratio were not statistically significant, though in the graph you can see the RR interval shows a increasing trend in the experiment session while the subject was performing 2-back task. So that indicates a relaxation effect, that RR interval is increasing and heart rate is increasing. Same you can see in the LH-FH graph. There is a decreasing trend of low frequency and high frequency ratio in the when the citrus odor was given to the subjects. Coming to the EDA and PPG parameter, the change in the skin conductance level has shown a significant result in the experimental session when citrus odor was given. Other parameters were not statistically significant. Coming to the discussion, cognitive task increase the cognitive load by activating the, it may be due to the substantial arousal of the sympathetic cholinergic system, which can be seen with the increase in the skin conductance level. Coming to the role of citrus odor here, the citrus odor, according to its association with the limbic system, reduces the cognitive load, and it has a counter effect on the sympathetic cholinergic discharge that can be seen with the decrease in the sympathetic, with the decrease in the skin conductance level. Citrus odor may activate the parasympathetic system also by the vaguely mediated HRV parameters that we have seen. These all findings are supported with the literature. Coming to the conclusion, the 2-back task imparts cognitive load and evokes changes in the skin conductance level. Exposure to citrus odor has a stress suppressing effect and improves the performance in the cognitive task. Citrus smell shifts the autonomic balance towards the parasympathetic system without an overall change in the heart rate variability. Citrus odor may be presented in stressful circumstances for its potential effect on cognitive performance and stress suppression. Thank you. So we have used pure essential citrus oil. Yes, sir, essential citrus oil we have used an aroma diffuser in which a fixed ratio of 100 microliter of essential oil and 100 ml of water was kept in the capacity tank.
Yeah, so did you rule out in exclusion criteria if some person is allergic to citrus odor?
Yes, ma'am. Prior to the recruitment, we have sent a Google form to all the subjects, and with that Google form, we have collected some demographic details, and we have excluded the subjects with the help of that Google form only.
So can you just summarize what is the effect of the citrus? What is the effect of citrus?
Yes, ma'am. Ma'am, the citrus in our study has affected the cognition, but what we are trying to study is the stress suppression role of citrus. So via the stress suppression role, via managing the stress,
the participants have improved their cognitive performance. And these parameters we have assessed through the autonomic nervous system, which is the strength of our study. So we are giving you an objective data of the assessment that we have done.
Any study before regarding this? Have you seen any study?
Ma'am, no. But studies are there regarding the separate, yes, ma'am, separate studies are there, but there was no study found regarding the association that we are trying to find out.
That's the first time.
Yes, ma'am. Yes, sir. Thank you, sir. Exclusion criteria. Sir, we have excluded the participants who had upper respiratory tract infection, who have any chronic illness, the subjects who had any known allergy to the citrus odor that we are giving. If the subject has excessive sweating because we are taking electrodermal activity, and if the subjects are using any kind of drug that affects the cognitive function of the subject, cognitive performance of the subject.
Thank you, Deepshikha.
Thank you. Thank you, ma'am.
Now I call upon the next presenter, Jill Ajola. And she will be presenting her work on pulse wave analysis based comparative study of vascular stiffness between diabetic and non-diabetic hypertensive subjects of Bhavnagar city.
Good afternoon to all the respected faculties and the delegates. I am Dr. Jill Ajola, PG student from Department of Physiology, Government Medical College, Bhavnagar. And I am here to present my paper titled Pulse Wave Analysis Based Comparative Study of Vascular Stiffness between Diabetic and Non-Diabetic Hypertensive Subjects of Bhavnagar city. To introduce with, hypertension is a modern epidemic with coexisting more than 50% of the diabetes. So both the hypertension and diabetes is a cardiovascular risk. So early cardiovascular aging can be detected by the arterial stiffness. Stiffness is of course the bad prognosis, but that is not routinely measured thing because of the scarcity of the measuring devices. So we can measure the arterial stiffness by the pulse wave analysis that is non-invasive, validated and objective test that measures the two different parameters of arterial stiffness, that is pulse wave velocity that estimate the central stiffness and augmentation index that usually estimate the peripheral stiffness. Both the augmentation index and pulse wave velocity are increased with the arterial stiffness. In this slide of aortic pulse wave, it is shown that the first one is the forward wave, this one is the reflected wave, and there is an increased height that is known as the phenomenon of the augmentation, and that estimate the pulse pressure and then can estimate the incident hypertension. It can be manifested at the as the incident hypertension. In this slide, the pulse wave form of two form is here. In the normal form, on the left side, the augmentation is less in the normal or the healthy aorta, but into the right side, because of the increased arterial stiffness, the height is increased. So that can be estimated as the increased augmentation pressure, and then can be estimated, manifested as the hypertension. With this background, I aim to compare the measures of vascular stiffness derived by the pulse wave analysis in hypertensives with or without diabetes. In methodology, we proceeded by the taking permission of the IRB, and in my cross-sectional study, and with the returned informed consent that was taken from all the participants. At first, we took the 475 participants. Among them, we chose the 275 hypertensives. Among them, we recruited diabetic 107 and non-diabetic 107 patients, and they were matched by height, weight, and BMI. This slide is showing the instrument that we used, that is Mobilograph IEM Germany, certified by European Society of Hypertension. It is showing the recorder and the 4 size of different cuffs. So in the method, we used oscillometric pulse wave analysis, arc solver method. So in this slide, it is shown that by keeping the cuff of appropriate size at the mid-arm circumference and by keeping the cuff inflated for the 10 seconds at the diastolic blood pressure, we recorded the brachial pulse wave. Then after taking the multiple brachial pulse waves, we averaged that into the single brachial pulse wave. Then after, by the generalized transfer factor, we derived the aortic pulse wave from the brachial pulse wave. So by this, we can assume the so many parameters of the cardio CVS, and arterial stiffness is one of them. So we came out with the results. So in the both diabetic hypertensives and non-diabetic hypertensives, we divided the 2 groups. So all the groups were comparable for age, gender, BMI, physical activity, mean blood pressure, and heart rate. So we can see that the except the confounder diabetes, all the other factors, aortic pulse wave velocity, augmentation pressure, augmentation index, and reflection magnitude were comparable, but there was no significant difference was there. In the discussion, main outcome was the groups were comparable with the all confounders, but the hypertensives had the higher aortic pulse, augmentation pressure, pulse wave velocity, and augmentation index, though the diabetics and non-diabetics had comparable all the 3 factors. So what does it mean? So aortic pulse wave velocity that estimate the central arterial stiffness, and the augmentation index that estimate the peripheral arterial stiffness. Both these can be the cause of the vascular progeria, and that can be the cause of the cardiac workload. But the diabetes has no significant impact in any of this, in any of the vascular progeria. So there is a lack of association between the stiffness and the diabetes. So this can be the causes that all the diabetics with the hypertension receive antihypertensives, which has the same effect. Then the hypertension is an aftermath of diabetes because of hypertension has more CVD risk than the diabetes. Blood pressure lowering in diabetes improves the BP dependent stiffness. So all the diabetics where the patients were diabetics, but still the blood pressure was lowered, and it might be led to the decreasing in the vascular stiffness. Vascular progeria is the preceding effect than the diabetes and the hypertension. To conclude with the middle-aged hypertensives, there is accelerated vascular aging indicated by the raised arterial stiffness, and that is independent of the coexisting diabetes, needing the further studies for the reinforcements, pointing to the future risk of CVD with hypertension more than the diabetes. These are my references. Wishing you all healthy cardiovascular life. Thank you.
Thank you. Very small query. What did you expect when you planned this study?
Sir, usually there is a...
We make some hypothesis when we plan research study. What was your expectation? What were your hypothesis?
Sir, because of usually the studies are done in the tonometry, that is used by the regional studies, but this is I'm doing by the oscillometric studies, so we can directly estimate the
group. Your main purpose was to differentiate whether some difference exists between diabetic and non-diabetic hypertension. If I read it correctly, that was the main emphasis. What was your expectation at that time?
If diabetes has any effect in vascular progeria or not in hypertensive subjects. if the chronic hypertensive, they are taking medications of antihypertensives and antidiabetics for more than 6 months. So the effect of that also.
Another added question, what is this word progeria? I don't know. Aging.
To ask the same question about the hypothesis. What was your hypothesis before starting?
The same thing, ma'am, diabetic Okay. Yes, yes. Sir, sir, because of the results. Yes, sir. So it is a normative, yes, sir. But at the first, it is a normative data, and we wanted to do the normative study. Yes, sir. Normative study. Data, sir. Yes.
Invite Dr. Mansi Jain.
Yeah, this one. Good afternoon, everyone. So I'm Dr. Mansi Jain. I'm a final year junior resident in Department of Physiology at AIIMS, New Delhi. And I shall be presenting a part of my thesis work and titled as Low Grade, Low Body Negative Pressure Causes Sympathoexcitation, which was an HRV study. Following mentioned are the co-guides and guides for my study. So title as we read, that is low grade, lower body negative pressure causes sympathetic excitation, which we saw in the form of HRV analysis, that is the heart rate variability. Before proceeding to the aim, objectives, material methods, let's have some introduction and background of how we came onto the study. So I would like to talk about two things, that is non-hypertensive hypervolemia. Now, as the name we read, it is saying that non-hypertension, that there is no change in blood pressure, but there is existing hypervolemia in our body. Now, it has been seen that this entity, non-hypertensive hypervolemia, is associated with activation of autonomic nervous system, which can be seen in the heart rate variability analysis in the terms of increased low frequency, which is indicative of sympathetic activation, increased in the LF is to HF ratio, that is low frequency is to high frequency ratio, which indicates about the sympathovagal balance in our body, decrease in the high frequency, which is indicative of the parasympathetic system, and associated with minimal heart rate changes. Now, this was corroborated by a study in our department in my lab as well, which was done. Then I would like to talk about low body negative pressure and why we used this as a model for my study for non-hypertensive hypervolemia. Now, the benefits of using low body negative pressure is that it's a beautiful tool. It is a non-invasive technique which can be used for simulating the central hypervolemia and inducing autonomic changes. By central hypervolemia, I mean to say
that since in the low body negative pressure, the fluid is being shifted to the lower limbs. So we are trying to fool our receptors, which are located in central regions. So by fooling the receptors that our body has gone into hypovolemia, we are trying to create and simulate non-hypertensive hypovolemia using this model as low body negative pressure. With this, the aim of my study is to determine the level of LBNP, which is sufficient to cause sympathetic activation in our body. In my study, a sample size of 33 healthy human volunteers was taken, aged between 18 to 45 years, which were all healthy, excluding the known cardiovascular diseases, any peripheral vascular disease. So they were excluded from the study. And the parameters that were acquired were continuous lead to ECG using the LabChart Pro 8 software. And the second parameter which was acquired was beat-to-beat blood pressure monitoring, which was acquired using the phenometer. And then the low body negative pressure machine, which was used to create the negative pressure, as we can see in the image. Coming to my work plan, so I did a baseline recording for 10 minutes in the supine position, followed by which there was a 10 minutes exposure to -10 mmHg of negative pressure, followed by a -15 mmHg of negative pressure for 10 minutes, and continuous ECG and blood pressure monitoring were occurring during this whole procedure. Now, HRV, how do we calculate HRV from our lead to ECG data? So I used LabChart 8 Pro software for this. So as you can see in the figure 3, which is a representation of my data recording, that is beat to beat blood pressure and lead to ECG, we have selected a time data in a specific time window range which we desire. And then we will go to the HRV module of our LabChart, where we will make sure that our data source is lead to ECG and not any other channel. Then we will be classifying the beats in the beat classifier view in our HRV module and generating the HRV report. So these shall be the steps we shall be followed for generating the HRV report from our lead to ECG data in the LabChart Pro software. Once the HRV analysis was done, following were the results after the application of stats, which I did with the help of the GraphPad software. So the analysis was done in 2 domains, that is time domain and the frequency domain. The parameters which were taken in the time domain were SDRR, SDSD, and the PRR50. It was found that there was no comparable outcome after the application of -10 and -15 mmHg. But in the frequency domain with the parameters, that is the normalized low frequency, it was seen that there was a statistically significant increase of the p-value of 0.008. That is, it increased from the resting 46.76 plus minus 15.46 to 55.47 plus minus 17.40. Coming to the normalized high frequency data, which was seen to be decreased when we compared it to the baseline condition of the -15 mmHg of LBNP, that is a decrease from 51.43 plus minus 14.37 to 43.74 plus minus 16.31 and a p-value of 0.0037. Also, in the LF is to HF ratio, there was a statistically significant increase with p-value of 0.0028. It increased from the level of 1.08 plus minus 0.66 in the resting condition to 1.64 plus minus 1.12 in the -15 mmHg of lower body negative pressure. In the results, we can see the same, that there has been statistically significant difference when we compare the -15 mmHg low body negative pressure to the resting condition in terms of normalized LF, normalized HF, and the LF is to HF ratio. So when we sat with our data of an HRV analysis, it was seen that at minus 15 mmHg of low body negative pressure, there's a significant increase in the sympathetic activity, a decrease in the parasympathetic activity, and a sympathetic predominance in our body by an increase in the LF to HF ratio was seen when we compared it with the resting state. Hence, we can conclude that that a minimum level of minus 15 mmHg is required of low body negative pressure to cause sympathetic stimulation in our body. The future direction or research in my study, I would like to say, since we are looking at only the cardiac heart rate variability, we would like to look at the vascular parameters as well. Thank you.
Thank you. What clinical application do you suggest for this?
Sir, I would like to mention about that even like this minus 15 mmHg of low body negative pressure corresponds to about 500 ml of fluid. So even if a 500 ml of fluid is lost, our body is sympathetically excited and the homeostatic mechanisms are engaged. So
you
that
mean
will
to
be
say,
the
in the hypovolemia, hypovolemic shock, this negative pressure will help?
Sir, it's a model to simulate that. So hypovolemic shock has also different grades. So when we talk of grade 1, which is less than 750 ml, it is minus 15 corresponds to roughly 500 ml of fluid.
No, that is all details, but I am.
Yes, sympathetic activation would be there in grade 1 of the
Application, bedside application.
Yes, sir.
Okay.
So any other hypothesis was in your mind before starting the experiment?
Uh,
Except the shock. Yeah.
Ma'am, actually, like for me to be seeing that sympathetic activation is occurring at minus 15 and not minus 10. That was the curiosity. And of course, the vascular parameters, that is the total peripheral vascular resistance. So I've recorded that also, not presenting. Thank you, ma'am. Thank you, sir.
Extremely thankful for the judges for such insightful presentations. I would now like to invite Dr. K.K. Deepak to felicitate our judges for the session. I request the judges, Dr. Neelam Vane and Dr. S.K. Vajpayee, to be on the stage for the felicitation. Yes, sir. I now take the honor to announce the results for the poster presentation, institutional poster presentation competition held at our institute. The third prize goes to Dr. Varun Malhotra Loud applause for the winners. I would request the judges for the same, Dr. Mary Vibha Lakra and Dr. Sujata Gautam, to please be on the stage to present the prizes. Loud applause for Dr. Varun Malhotra. Third prize in institutional poster presentation. Dr. Varun Malhotra, third prize. The second prize goes to Dr. Suman Das. Second prize for poster presentation goes to Dr. Suman Das. Dr. Suman Das, please be on the stage. Dr. Deepthi will take the award on his behalf. Any guesses for the first prize? First prize goes to Dr. Sankalp Jha. Congratulations to the winners. Participation, since, is even more important than winning. I request the judges to please give the participation certificate. Dr. Sujata Ray Chaudhary. Dr. Sujata Ray Chaudhary, please be on the stage. Dr. Simran Kaur. Dr. Tulika Rajawat. Dr. Tulika Rajawat. It's written on your. Tulika Rajawat. Dr. Shravanti Bhattacharya. Dr. Sujata Ray Chaudhary. Dr. Shravanti. It was worth mentioning to honor our judges who beautifully conducted the session. I request Dr. Pandey to please felicitate our judges. Dr. Sujata Gautam. Dr. Mary Vibha Lakra. Dr. Shravanti Bhattacharya is here with us. Certificate of participation for oral paper presentation. Dr. Shobha MV. It's a participation. We compile this. Dr. Sangeeta Bhavra.
Good afternoon, everyone. After 2.5 days of afternoon again. After 2.5 days of deliberations, we have come to the point where we will formally be giving validatory function. That I'll leave it to the organizing committee to do that. Before we do that, I want to share with all of you that in its wisdom, the association over last 60, 70 years have instituted various awards, nominations to recognize our own members. मैंने on कर दिया, but I think वो amount. So in its wisdom, the executive committee members of the yesteryears have made number of awards to recognize the efforts of our own members. And some of the awards are nomination awards, which somebody nominates, seconded. There are a list of awards. I would like request all of you to go through these awards and spread the word, because many a times our unawareness leads to non-applications and non-nominations. And there are awards which are for the recognition of published or unpublished manuscripts. And there are 8 of these awards. Over time, they have been instituted. Some of the awards are which are decided during the conference. For example, the postgraduates, undergraduates, poster awards are there. We will begin the recognition of our members, beginning with the nomination awards. And to assist me in the process, I will request the heads of the organizing committee, that is Professor Asim Das, organizing co-chairperson, chairperson rather, Dr. Shivani Agarwal, to join us on the dais. From the side of the executive committee, I will request the General Secretary, Professor A.K. Pandey, and the Executive Editor, IGPP, Professor Deepak, to come join us on the stage. Sorry, I missed Dr. Monica, the co-organizing secretary, also to join us, please. There are 5 different nomination awards, of which 2 are the oration awards and the others are for recognition. And for the best teacher award, we have with us Professor Neelam Vane. And Madam, may I request you to come on the stage and accept our appreciation of your hard work as a teacher for years. It's a proud moment as physiologists to have a teacher being recognized. So we can have a big round of applause for her. So while we were making designing the trophy, we'll also make a big trophy. And so now we'll make something that can be kept at the table to recognize, make her remember that. And whenever somebody comes on your table, it's a small thing that is, we can keep on that. So that's why we have this smaller version of the whole thing. But the small thing magnifies, or it's being a glass about what all it can encompass. Thank you, madam, for being with us and part of the APPI. We are happy to see you as a Best Teacher Award. Yes, sir, please.
She is also best physiology editor I have ever seen. Like I've worked with her and wonderful, marvelous.
I'll just expand on what Professor Deepak has telling. You must, all of us know that the IGPP, due to technical issues, was out of the midline, and we needed people to get the technical things done right in right time, and that's where the recognition of Madam Sir is saying. Thank you, Madam, for that effort. Please.
So I would like to congratulate ESI Hospital and especially Dr. Aseem Das, Dr. Pandey, and the full APPI team for the successful this conference. And I would like to, actually I'm honored to get this prestigious award. And I would like to thank my learned teachers for their guidance and the colleagues and the students who have joined together throughout my period. And as Dr. Deepak said, I would like to thank my editorial team and the reviewers who have really helped me to work along in this journey. Thank you. Thanks a lot.
We are moving on. We have about 8 awards for published or unpublished work. And I'll go them in the order, not necessarily in the order of importance, but in the order of the way I've got the list. So we have a paper, best research paper published in physiology or pharmacology, instituted in the name of Professor B.K. Anand. That award has been received by Dr. Angel Anna Zakaria. I thought maybe she's around. Okay, Dr. Simran will receive the award on her behalf. So let me repeat, this is the award for best research paper published in physiology, instituted in the name of Professor B.K. Anand. It was instituted, one of the first awards that were actually instituted for the published papers for us. Congratulations, Dr. Simran. Congratulations to your student, Dr. Angel Anna Zakaria. Maybe you can just stay there again, because the next award I'm going to announce is the best research paper in relation to development of new techniques or instrumentation in physiology, pharmacology, or allied sciences. This was instituted in the name of Devraj Bajaj. And as it so happens that Dr. Simran is the recipient of the same award. So yeah. Thank you, Dr. Simran. The next award is for the APPI award for best research paper in cardiovascular physiology, pharmacology, or allied sciences in the name of R.C. Shukla. And this award is given to Dr. Prachi Srivastava. Thank you, Prachi. Thank you, Dr. Prachi. And thank you, Dr. Deepak, for being with us. Thank you. The next award is for the best research paper in natural health, naturopathy, yoga, instituted in the name of Sushila Thakur Prakriti Mandir. This award is given to Dr. Sankalp Jha Dr. Sankal, please. Thank you, Sankar. And there were other awards for which we did not need any applications, so I'm not reading them. The last award should be presented for the 67th APICON is the APPI Award for Best Published Paper in Indian Journal of Physiology and Pharmacology, instituted in the name of Professor G.K. Paul. And the award is given to Dr. Ravindran. There he is. Dr. Ravindran. He's very active also in when we were making the website. Yeah, first. Thank you. Congratulations, Raven. We had so there were no applications. Okay, sir. No, so there is a best APPI research paper. The way we have begun for physiology, its counterpart in pharmacology is Dr. C.L. Malhotra. That award, it was one applicant, but it was on the technically because he was not the first author, because these awards are given to the first author of the paper, and just because right, not awarded. And then I've forgotten the list now. Okay, that's correct, sir. Moving on, we have now we had a session of undergraduate as well as postgraduate presentations, and the in live sessions the judges have made their decision for the APPI award for best paper presentation for by a postgraduate during APICON. This was instituted in the name of R. Srinivasan. May I request Deepshika? Where is Deepshika? Yeah, Deepshika. And Manasi Jain to come up on the stage. The judges have apparently given me two lists together as a joint recipient. Your trophies will come with the name after some time. So we only get the certificate right now, but the trophies will be sent after we will be able to print the name, etch the name onto the trophies. What are these? Deepshika, Manasi. Thank you, Deepshika. Congratulations. Dr. Manasi Jain. Thank you. As the sessions were going on in the this hall for postgraduates, similar sessions were going on for the undergraduate presentations, and there's an APPI award for best paper presentation by an undergraduate during APICON, instituted in the name of Dr. Harish Gupta. May I request Shivani Chaurasia to come and receive the award, please.
Hind Institute of Medical Science, Barabanki.
This is the first time that we will be announcing the awards for the poster presentations. To encourage participation in the poster competitions. Professor T.R. Raju, in his wisdom, had instituted this award to recognize two posters. These are, we don't call them as one or two, two posters which have are recognized to be awarded. May I request Dr. Pooja Kumari? And Dr. Hina Parihar. So Dr. Hina is not around. We just give to Dr. Pooja Kumari. Sorry, and there is this is one of the only prizes, perhaps there is a cash award. that was so there is a cash prize of 5,000 rupees to Dr. Pooja Kumari. Yeah. Oh, Jirin has come nicely to take the award for his friend. So when there's money, a lot of people do come. Jirin has partly come forward immediately. So may I request Dr. Jirin to take the award for Dr. Hina Parihar. Last year, we had to do an online only awards presentation. Therein, we could not gather like this. The awards were announced online, and we had requested them to be able to come over here. Not all of them are here. So what we will do is, sir, we will just narrate their names and announce the names. Right, so next time, sir, I'll take the printout. Just load. The last year, we had one nomination award for Professor Baldev Singh Oration, and that was given to Professor S. Jaseja. He was very kind enough to be present online and give his presentation in the last one. So all we can do right now here, since he's not around with us, we just give a round of applause for him, and we'll send the certificates and the trophy to him by post. I'll read out the other names that were there. And so the best research paper published in physiology in the name of Professor B.K. Anand was given to Dr. Sunil Jamuna Tripathi. Best research paper in development of new techniques and instrumentation in physiology, pharmacology, or allied science in the name of Dr. Devraj Bajaj to Dr. Barun Sharma, Hanjamam Barun Sharma. Best research paper in cardiovascular physiology, pharmacology, or allied sciences in the name of Dr. R.C. Shukla was given to Dr. Kirtana Kunikulaya. Best research paper in pharmacology, in name of Dr. C.L. Malhotra, was given to Suvarna Chakrabarti. One of the recipients is around with us, I think Dr. Kumar Gandharv. Yes, please. Last year, the best research paper in natural health, naturopathy, and yoga, issued in the name of Dr. Sushila Thakkar Prakriti Mandir, was given to Kumar Gandharv. So may I... Thank you, Kumar, for coming all the way to receive your prize. May I request Professor Deepak to hand over the prize to you. Congratulations. Thank you, the member of the executive committee and the organizing committee, to be part of this presentation. Thank you very much, sir. May we take the seats.
Good afternoon, everyone. On behalf of APPI, we would like to felicitate all the organizing team members, including Dr. Asim Das, Dr. Shivani Agrawal, Dr. Monica, Dr. Namrata, Dr. Girish, Dr. Salim. Please all come on the dais. Because we decided that organizing committee, usually they are busy, they are neither presenting paper or poster because they all are busy with that. So we should at least give them a letter of appreciation and certificate for that.
Dr. Shivani, Dr. Namrata. Pravina. डॉक्टर पांडे तो अभी जनरल सेक्रेटरी की एक्ट में है, so he has a dual duty as a general secretary as well as the part of the organizing team. Yes. Yes.
And all the organizing committee members. So you must have realized that the online connectivity was very nice this time. And so that's Dr. Meshram.
One could see Dr. Meshram constantly sitting on that chair that side. He could not go take any break because the sessions were always on. All of us could go out and have a cup of coffee.
Just not during the session, but before the session.
And Dr. Revan, he is a recipient of previous year's R. Srinivasan Award. Revan, RBBN. Yes. ठीक
Dr. Prachi also complained to me that I missed her announcing her last year's prize. Dr. Prachi Srivastava had also received last year the best paper, research paper in endocrinology in the name of A.V. Tilak Parvati Devi. Prachi, please.
पूरा नाम क्या अच्छा काम्या टेटवाल from 2018 batch ESIC Medical College Faridabad. She is the recipient of previous year Harish Gupta Prize. Now I think we have declared all the awards, prizes for previous year as well as this year. Previous year we just hold mostly online, few only recipient present offline. So we thank you for and congratulate for both the award winners of Epicon 2020 as well as 2021. So I request everyone to give a big hand for all the recipients of the awards as well as prizes. Now it's my responsibility. If you see from last 4 days, starting from workshop to the whole 3 days event, there was uninterrupted virtual sharing of all the knowledge, presentation, video, workshops. So I think we should not miss to acknowledge and thanks to Java Enterprises team LCF and Mr. Grover from Honey DJ. Now because he has to arrange some event today only from the evening, so I asked him to be with us by 2:30 and mostly I think we finish within time. Though today it was proposed to be everything finished by 2:30 including valedictory function. So even for we started even late or whatever, but we know how to manage the time and I think we are reasonably good in time management. So again, very thank you to Java Enterprises. It was excellent video and virtual platforms area. I am just going through YouTube as well as Facebook, and we have all recordings and video of all the event. We will share with Dr. Jarial so that we can upload on the website for those who have not attended, they can see that. So thank you everyone. Thank you very much. And for Ghazal Caterer, if you see the delicious food starting from 13, 14, 15 and today from breakfast to the lunch, the evening tea and throughout, because we manage the time because we never have a tea break because they used to serve the tea coffee inside the hall. So I think Ghazal Caterer also deserve a big round of applause. Our sponsor, yes, because without sponsor, without fund, you cannot hold a event, a mega event like Epicon. So we appreciate and thanks to AD Equipment, the Biopack, the Sanofi Genzyme, and many other sponsors who have not put their stall here, but they supported us, the ESIC headquarters, and especially Dean Sir's effort because he converted the sanction for the event into for these national conferences. So thank you everyone. Thank you all the faculty and delegates. Thank you everyone. Institutional award oral presentation. Okay, ठीक है बुलाओ. I think 3 missed we can give the award. ये फर्स्ट है अच्छा ये डेली का है ना 3 days. Okay, best oral presentation award DAY-3 actually sir proposed that there should be one institutional award for every day best oral presentation. So ये किस डे का है, डे वाइज बताते जाओ। अंजू का किस दिन का है? कंबाइंड है, फर्स्ट, सेकंड एंड थर्ड। ओके फाइन। So Dr. Anju Bhardwaj, the best oral presentation of all the 3 days. May I request Professor K.K. Deepak and Dr. Charyal and our Dean, Dr. Asim Das. Dr. Anju. Dr. Deepti Chopra, is she present here? She got second prize. अच्छा, वो फार्माकोलॉजी की है ना? हाँ जी, डॉक्टर दीप्ति चोपड़ा, आप रिसीव कर लो आके उनके भी आप। डॉक्टर मोनिका, मैं रिक्वेस्ट यू टू रिसीव ऑन डॉक्टर दीप्ति बिहाफ। डॉक्टर किरण प्रकाश, डॉक्टर किरण was here, I think she left. Anyone can receive on behalf of Dr. Kiran? और कुछ? डॉक्टर नीलम वानी को क्या है? जज, अच्छा हाँ, ऐसे I think now there is certificate to Dr. Neelam Vani for judging this Art Innovation Prize. Dr. Bajpayee, sir. Yes. Okay, thank you, madam. That's all about the valedictory function. Thank you, everyone. Thank you very much. Now we should go to वो, I think मैं दोनों में तो आपको
Ajay, please come. Group photo. So I think उसके लिए organize कर लीजिए group photo के लिए. आप ही बोलो.
मैं तो secret बोलूँगा, बाकी applause आप बोलेंगे.
Okay.
When this building was empty, that time Dr. Asim Das consented to organize this conference. कितने साल से चल रहा है ये प्रोग्राम, आज एग्जीक्यूट हुआ. So congratulations to the team, and we are extremely happy. Very good hospitality. कहीं भी जाते थे पानी नहीं मिलता है पीने के लिए, खाने टेंट हाउस में खाना खाते हैं, यहाँ तो एसी रूम में एकदम 5 स्टार से राउंड टेबल बैठा के खाना खा रहे हैं. And evening, though, I won't describe what we are doing. So, we are extremely happy. Now I'll do Dr. Deepak.
So, on the behalf of APPI and also from all members here, we really appreciate the way the team has worked, Dr. Asim Das and Dr. Pandey, and they have given a tea ad libitum. जैसे हम चूहे को खिलाते हैं ना, water ad libitum, जितना पियो वैसे हम लोग कितनी चाय मिली, आके चाय फिर coffee. So really we are very pleased to get this kind of a thing. And also look from academic point of view, they made sure that timing part, they had a very difficult time, but then they made sure academic content, and coming after COVID, it was a mammoth task doing. So we've been listening that it has to be done here, told by Dr. Malik, but then they have realized against odds, like not having something, not having this thing, but they have done it. So again, congratulations, and we are very pleased to have you, and thank you so much for all entire team. It's all dedicated team, the way they have given calls and then emails, and then they have taken care of, and without coming out forward, without taking self name, they have come. So it's a dedicated team, so we are proud of you, sir. Thank you so much.
From the point of the head office, because I take care of that, the decision had to be made in early February, whether we are in a position to hold the conference at all. And that decision had to be taken with the consent of the members here, because they're all executive committee member. And we were bouncing between offline, online, or postpone. The postpone was the easy option, but Dr. Aseem Das was very clear. Hoga to in person. Hona hi hona hai. Hoga to hoga. And he was, so this decision, sir, change occurred somewhere in middle of February, because you must have noticed that our mails came a little later, because we were not sure. They toyed between June, May, April, looking at all. In fact, we also considered March, because March was then the NEET admissions were occurring, so they had to be taken to April. Then the team actually, because I'm witness to the whole process, who actually geared up somewhere in the second week of March, because then, okay, now we got to start moving. And from that point, we only have maybe 40 days to this date, and it's a tremendous cover. And from the head office also, we were little also gingery whether we will be able to commit. And I think, sir, your ESIC brand has worked, I would say that, because the kind of people you could get to the academic sessions from Dr. Anurag Agarwal, Professor Garg, I think they all came not for an individual, but as an institute. I think ESI has done extremely well to get a traction. So congratulations, sir, to you, that because you've been leading the ESI for that long. And which basically tells that not only the Department of Physiology of ESIC, but I think the whole institute as such must be absolutely. And yes, because in the COVID pandemic, the way the department has worked, that I think that's where the traction has come, because the 2 years of work that you've done, and you brought even from the ministers to the industry, they are now running after Dr. Das and Dr. Pandey to do clinical trials for them. I think that's a great achievement, and perhaps that's the reason for success. That what the 3 days of success that we see today is perhaps 6, 7, 8 years of hard work. So overnight success is never an overnight success. It only manifests overnight. So what we have seen today in 2.5 days of here is a testimony to the hard work of ESI under your leadership for this long. We'll be very grateful, sir, from the APPI. Thank you, sir.
We should not forget, even last year, the online conference was organized by the ESI only, and we all participated in that, and that was also very.
मैं almost 20 years I was finance secretary. मुझे कोई कमरा नहीं देता था, कुछ नहीं देता था. This time I'm not finance secretary. I got a beautiful room to stay nearby.
No, the hospitality has been excellent, because as he's saying that we've had experience in the last 20 years, 25 years, me for 20 years, he for 35 years, to going to various parts of the country. We see the difference. The difference comes in spirit, both Dr. Malik mentioned, spirit in the day, spirit in the afternoon and the evening. So both were taken care of. Thank you very much, sir. With this, let's go and have lunch. Oh, yes. Oh, photograph. Ajay, sorry, Ajay, please. Yes, may I request all organizing committee pehle. Yes, so may I request the members of the ESIC who are around to just come up on the stage, please. ESI team. See, we have about 500 medical colleges, more than 500 medical colleges in the country. That means if a medical college has to get a chance to organize APICON, these photographs are important, because ये मौका 25 साल के बाद मिलेगा, because we are 500 medical colleges. APICON तो एक ही बार होगा एक जगह पर. So these are memorable moments for the SIC. Aja, please. PG आगे आ जाए, PG. आ जाओ.